Was our lead at NHS England for inequalities, but has hopped over to the CQC. So the fact that everyone wanted to come together and talk about it, and actually the fact that Baroness Merrin said, I'm going to take all the questions first. And I can tell you 100% there was no ego in that, but that was her saying, I feel accountable about this. I feel this is important. This is the most pressing thing for me. It's why it's in the manifesto. I will do the first answer first, because I have to be accountable to this committee. And it was really, for me, I was so impressed by that, because it's very easy to go, oh yeah, thanks for that question, over to so-and-so, or pass the questions around. But she really, really wanted to lean in. And the third thing that I think, I'm not saying this because I'm saying it that everything's all right, but the maternal death rate is now the lowest since 2013. It's down 17% in 21-23 from 2018-2020. So there is change happening. And I don't say this as complacency, it's all over, we're all done here, everyone can pack up and go home. That would be ridiculous to say that. We can make a difference. The things that you are all doing, the work that you're leaning into, is starting to see some of the change that we want. Not all, because not all of those statistics go in the right direction, but we are starting to see some change. So the first session was of the Health Select Committee in May. We heard from Birthrights and 5 Times More, who called out painfully the issues, which I think you are all aware of. Our focus was more on data, which I thought was interesting. And again, green shoot, but not the answer, and no reason for complacency, is that now 96% of women in maternity services have their ethnicity recorded properly. And that might say, well, you can't count things, you can't build a case, you can't give people good reason quantitatively why they need to make a difference. And you're going to hear from Nandi why things like that, about that, but when we went listening to the work of the Learning Action Network that Nandi's involved with, data has been a really pivotal point in unlocking people's attitudes and insight to what they're doing, but I won't say any more. Some of you will probably want to ask me about why there hasn't been a target yet. It was a government manifesto commitment. What I would say, very easy to say, we'll do this target, we'll set a target for this, and then unintended consequences fall out of it. Anyone who has followed the story of the 4-hour target in A&E, consequences that fell out of doing a target, but doing it without giving it due diligence, if you like. And the obvious one is the target is to reduce, you can easily reduce disparities if everyone goes to the same point, which is higher than where you start for everyone. Well, I've hit the target, but I've completely missed the point. So we need to think about how we frame this target. We need to, how do we judge it? How do we want everyone to come up in terms of their chances improve, compare ourselves to? How do we set a target that starts to show change happening and gives people hope and courage to keep going when they're distracted by a ridiculous inbox? Thinking about is whether or not we need to think about maternal mortality as a proxy indicator alongside this, because maternal death is really rare. And it's really important we say that and say it in an unafraid way. That is not to say that every death is not a complete and utter tragedy. No woman should die around the time of having a baby, either just in early pregnancy or after she's had a baby, which is when we know most women die. That is every small. And the thing about small numbers is that they're very subject to wobble, if you like, from a statistical point of view. And you can say, oh, we've done it, look, it's come down. And actually you haven't done it. So we are thinking about whether we need mortality indicators that go alongside that so that we can track our progress in real time. We have a degree of sensitivity to what we're doing and we overcome the time lag. So please don't think that isn't happening for a reason, that we're just not getting around to it. There is a lot of thought and a lot of much bigger brains than mine thinking about it. Many of you will be aware we asked ICBs to look at their equity and equality in their own areas. And a lot of people said, oh yeah, you can ask people to write a plan, what difference does it make? The Equality Commission have done a review of that and have said we're seeing more collaboration, we're seeing more work with service users, we're seeing an improvement in data, and we're seeing projects. And you're going to hear more of that from Agnes. And again, I would probably say is my other key priority, working with our service users. If we don't listen to our communities, we will not get this right. Localisation of what we're doing is so important, and it's a really interesting one then, being in a national role, because everyone says to you, why don't you just do something? Well, yeah, I could say anything you like, but it wouldn't make any difference, because if it's not meaningful to serve and provide services for, it will not make a difference. And really interestingly, Wendy Oliawola, who many of you know, who's the maternity lead for inequalities, she talked about a clinic that started up in East London, and it was a high-risk clinic for black women, and women didn't turn up because someone had a good idea. There's a problem here. Let's put a high-risk clinic in. Okay, well, fine, but what does that got to do with me? You know, do I want that? How are you labelling me? What does that feel like for me? What assumptions are you making? And what are you going to do to me if I... Really powerful reminder of the need to work with your community, take advice, listen to service users, listen to what the needs are that will make a difference, and make education and personalised care. I think this afternoon, who I am very privileged to work alongside. I'm a massive fan, bit of a fangirl of Jazz, so you're lucky to hear from her. And she is working and leading on personalised care. So the plans around the system, we're starting to see change. Again, this is all shoots, it's not reason for complaint. Are very aware of this tension between localisation and nationalisation. A review right across the evidence base for tackling a big evidence base. There's lots and lots of projects going on, but we don't have a clear direction of travel. And that is why the work that Nandi's leading in the RHO is so important. So individualised care, as I've just said, access to care, making sure you don't make assumptions when someone's sat in front of you about who wants the opportunity of a home birth, who wants the opportunity of genetic testing, who wants the opportunity to have an elective section. Are you making assumptions based on what you think you know about someone sat in front of you? Are we managing conditions properly? Who is this person in front of me and what do they need? Rather than saying, this is the condition of X and this is how we deal with it. Those two things are not the same. And finally, racism. The NHS is a microcosm of society. Maternity is a microcosm of the NHS. We know that racism and discrimination exists. Some of it is not done deliberately. The causes is the same, and some of it will be frank racism. We know, as I say, that people experience it. We have all read the reports and had the sleepless nights thinking, how do we change this? So we have a direction of travel on the things that we need to lean into. But I want to finish on hope. I want to talk about some of the projects that I have seen that when I go and visit teams and services, I've seen and I've just thought, God, you're amazing. Aren't you brilliant? So I went to Warrington and this team, they have employed someone who just works with people who have complex lives, who will do outreach visits, do parent education in their own home. And already they're measuring what they're doing and starting to see change. I went to Walsall and a midwife had banged on the door of the local authority and said, oi, these women, it happened, amazing. I went to Cambridge and they had unpacked all their data, outcomes, serious incidents, what was happening in PMRT, pulled it all apart and disaggregated it by ethnicity because they wanted to challenge themselves and say, what is going on here? I went to Leicester. Many of you will know about the JAMA app, but I had the privilege of meeting the people who put that app together. Localised support for local women. BHRUT employed bilingual doulas to be alongside people, again, being where they resource on assessing jaundice in neonates with black and brown skin. Our own work on Capital Midwife, the anti-racism framework, continues to grow slowly. So I just want to say no one is complacent. You have leadership and the ears at every level of the service. We are all 100% committed to this. We are determined to keep going. But some of my favourite things, local initiative, the passion and drive to improve this. Thank you.
Thank you very much. I think Kate has to go unless does anybody have any burning questions they want to ask her or any comments? No? Okay. So thank you so much. Have a better day. Hope their emails are a lot shorter.
Yeah.
And less in that. Gosh, it's really heavy.
Yeah.
You don't need to do weightlifting with that. Yeah. Fantastic. So just to have a little bit of an overview of why we're doing of our sort of thinking about the challenges that we've had within maternity in really learning how to create a system and a place that is equitable for everyone. Is that maybe, are we doing too many lectures? Because only 5% of us learn by lectures. Then we add on a bit of reading, 10%, audio visual, maybe a few videos you've watched. We then demonstrate and we discuss, even then, actually then we move a little bit into practice, and that's 75%, 90% teaching others. So we're hoping to showcase a little bit about simulation because we think it's really, really important, and it's really just getting you to think, how do you train differently? And so we're just going to move on in our programme. Really, really honoured to invite Nandi to come and speak. She's the Director of Implementation with a really, really fantastic profile and skill set and critical thinking, and really looking deeper into why does this exist and how can we challenge it and change it. Otherwise I need to get your presentation up as well, so let's go. Which one is it? So we are PDF. Oh yeah, fantastic, excellent.
Thank you very much.
Great. Yep.
Thank you. Wow, thank you. Honour to be on this agenda with all these incredible people and in this room with all these incredible people. So really thank you very much, Karen, for the invitation, and real privilege to be speaking on behalf. Put your hand up if you've heard of the NHS Race and Health Observatory. Oh look, loads of people. This is brilliant. Wonderful. Great. Okay, so Karen, about understanding maternal health inequities. Oh look, I did this as PDF. Sorry. A bit rubbish. So what I'm going to do is I'm going to talk briefly about, talk a bit about the Race and Health Observatory and our way of working, because I think actually, so I come from an academic background, and I think it's quite an unusual, for somebody who's worked in an academic kind of context, or somebody who works maybe mostly in a clinical context, it's quite an unusual way of working, and it's actually quite effective the way that the observatory works. So I'll talk a bit about how we work as the observatory. Hopefully there'll be a bit of time for questions, although maybe we're doing discussions separately, so we can do that separately if that's the case. Okay, so ethnic health inequalities are widespread. We all know that black and brown babies have the highest rates of stillbirth and infant death. We all know that black women are almost 3 times as likely as white women to die in and around. But the COVID-19 pandemic really, as well as exacerbating these these ethnic health inequalities, also highlighted the issue, so it became much more prominent around the time of the outbreak of the COVID-19 pandemic. And it was in this kind of context that the NHS Race and Health Observatory was established. So it was established in 2021 with a remit to ensure that the NHS has access to the best possible evidence and resources to address inequalities. So one of the first things that the organisation did when it was established was to commission a piece of research from researchers at universities of Manchester and Sheffield. And what we asked them to do was a rapid evidence review around ethnic health inequalities in healthcare. And so the review, which was published, evidenced the damaging role of experiences of racism both on individuals' health but also on healthcare more generally, or more widely. There were incidents or angles at which this was manifest. So, for example, around mental health, there were really clear barriers to seeking help for mental health issues, which were of the care that was being provided and the care system, but also a fear of being discriminated against. So, barriers to access, essentially. The review also found that in some of our fundamental processes that support the development and of research and of medicine, there was poor representation of people, for example, in large genome-wide association studies. The review found evidence that NHS ethnic minority staff endure racist abuse, not only from patients but for people who are black. Pertinent to what we're talking about today, and I'm sure you'll all be familiar with this, in maternity there was a consistent theme around women's experiences of negative interactions, stereotyping, disrespect, discrimination and cultural insensitivity. So this this report actually gained a lot of attention, and it gained a lot of prominence. And one of the reasons for that is it was one of the first times that racism in particular had been called out in the NHS. So there was, made quite a lot of impact in the kind of public sphere as well when this. Oops. So talking about race and racism, when we're in the Race and Health Observatory, there are obviously access to services and resources, differential experiences within the healthcare system, and diverging health outcomes when compared with the white majority rules, and undermines the full potential of the whole of society. And when we think about racism in the observatory and our work around acting to combat racism or in and around the NHS, really focuses on an understanding that racism manifests in different ways and different and intersecting ways. So structural racism, which impacts or affects the social determinants of health, so socio-economic context, resource distribution, legislation in the legal system, education, employment, all of these things, conditions in which we are born, live, grow, work, etc. Interpersonal racism, cultural assumptions, behaviours, stigma, trauma, and that these different forms of racism become embedded and perpetuated through institutional racism. So, for example, through policies and practices that we establish in the organisations that we work in. I've shown you this first slide of the massive range of areas in which there are ethnic health inequalities, and many different ways in which race manifests. So we're focusing our attention in the observatory. For the next 2 years, our strategic focus will be aligned with the 3 shifts, and specifically includes maternal and neonatal health. So maternal and neonatal health has been in the focus of the observatory since its inception and continues to be one of our main priority areas. As based around what we rather inelegantly call the 3 stools. So this is our approach, which is essentially, sorry, I know it's ridiculous, isn't it? So what the first part is around synthesising insight. So this is really about collating evidence, and where there are evidence gaps, commissioning. So since its inception, the observatory has published 20. Those was actually launched yesterday. That was a comparative research report into sickle cell disease, well worth a read. Forming policy. So the observatory, we're in a really privileged position. We've got access to and the ear of many senior policymakers in this country, and that's something that we recognise and value and use to our best effect. So, for example, work that we did at the outset of the pandemic around pulse oximetry and measuring oxygen saturation and inequities in that depending on skin colour, prompted an independent review into equity of medical devices. Work that the observatory guidance around jaundice in newborn babies. We also have recently published, at the end of last year, we published a set of anti-racism principles, which I'll come back to, and as an organisation, but also in their investigation. So we're working with them on how those can actually be made into generate practical. And then the final leg of our stool is enabling transformation. And this is some of the work that I'm going to talk with you about today, which is our Learning and Action Network. So this is really about how do we work with practitioners to identify and pilot approaches that can actually be successful on the front line and in day-to-day practice. So this is our Learning and Action Network. So the Learning and Action Network was developed because there's been to date a programme which is focused specifically on racial and ethnic health inequalities in maternal and neonatal care. And we also know that there are evidence gaps around interventions which specifically address or reduce maternal and neonatal ethnic health inequalities. So we established the Learning and Action Network with the assumption that the persistence of these health inequalities that we see could be attributable as a determinant of health in this case. And what we've been aiming to do through this Learning in Action Network is to develop an anti-racism focused quality improvement approach that supports practitioners to identify and address racism within maternity, racism in services, and improve maternal and neonatal health outcomes. So the Learning in Action Network is, we were enormously fortunate to partner with the Institute for Healthcare Improvement to do this work, and with support from the Health Foundation. And what we're doing is we're working with 10 teams in 8 in one overarching aim. So the overarching aim is to reduce clinically avoidable severe maternal morbidity. And back to Kate's point, we focused on severe maternal morbidity because for every mortality there are around 100 severe adverse events, and perinatal mortality and neonatal morbidity, while improving the experience of pregnant women and PT ethnic groups. So that's the overarching aim. Each of the teams has identified a specific area of focus which relates to one of these 4 comorbidities: perinatal mental health or preterm birth. It says here that the programme was to run for 14 months. We're actually in our 18th month currently, and we're continuing for a bit. We're going to continue. So the Learning in Action Network is, for those of you who aren't familiar with it, it's a quality improvement based approach. So what happens is that the teams are all working on their individual quality improvement programmes. They have coaches from the Institute for Healthcare Improvement, and then they come together periodically. So we've had 4 learning sessions where teams have come together for intense periods over 2 days to exchange ideas about the way that their projects are progressing and the kind of barriers and facilitators that they're experiencing. So that's the kind of Learning in Action Network approach that's a standard, and what we've done is we've overlaid into that some anti-racism components. So the first of those is the focus on conditions where there are ethnic health inequalities, significant ethnic health. The second of which is embedding the WHO anti-racism principles in a second. But what that really is doing is we're looking at racism as a determinant of health. So we're really putting that focus onto how racism is operating and how we can address that in the services. So teams are testing anti-racism interventions as well as clinical interventions, and we're coming together, we've brought teams together for learning. So we're working with the evaluation partner, and they keep talking about training. We're not doing training. What we're doing is shared learning. People are coming together, we're holding space for conversations about race and racism and exchange of information, and exchange of ideas and exchange of experiences we've been doing around our anti-racism webinars and as part of our learning sessions. And the final point around this is, so Kate alluded to at the outset of this talk, the evidence in maternal and neonatal care is really, really thin. In fact, around anti-racism interventions in the NHS is just thin. So what we also are doing is we're working with an evaluation partner, and our aim here is to identify evidence about what some generalisable principles are and what can be applied more widely about the NHS, about the WHO anti-racism principles. So first of all, we didn't invent these. These exist. You know, what we've done is we've pulled them together, and we're often approached in the WHO, and people say, "Listen, we know we've got a problem, but we don't really know what to do." So what we did was we put these together as a kind of set of things to consider, and QR code should take you to our website, on which we've got some briefings. We've started working on some briefings around these anti-racism principles, and we're going to develop sets of tools. Cindy over there, who's our head of implementation, she's working on a programme at the moment to develop sets of tools which sit underneath each of these principles. So the first principle, naming racism. Hands up if you have not heard of Professor Kamara Jones. Way to ask that question, actually. Sorry, didn't mean to shame anyone. Okay. So it sounds like quite a few people have heard of Professor Kamara Jones. She's one of my heroines. She's amazing. So she's a physician, and was former president of the American Public Health Association. She's a thought leader in the area of she's an academic activist and thought leader in the area of race and racism in health. And so she has got a really beautiful definition of naming racism. So what she defines naming racism, 3 separate actions, or 3 kind of distinct actions. The first one of which is acknowledging that racism exists. The second one is committing to understanding how racism is operating here. And this is something that the teams working in our Learning in Action Network have embraced, and you're going to hear later on from Nushin and really amazing example of how this can, translate into actual change in real life. But this is not easy, and I think one of the reasons we extended the Learning in Action Network is because actually gaining traction around this idea and gaining not even the comfort, but gaining the ability to have the kind of conversations that are next on racism takes time. Okay, so the second one is about understanding and acknowledging how racism exists and manifests. And this really comes back to the point about the different kind of intersecting levels at which racism exists. So, that interpersonal, organisational, structural racism. And recognising that, for the short window of a particular experience, but they may have come with a lifetime of experience of discrimination and bias behaviour that they are embodying in some way. So the third point is about meaningfully involving racially minoritised individuals and communities. And the point that I'm sure everybody here will know, but it's like this really important point about building trusted relationships, taking the health system at recognising or we don't necessarily have systems set up in a way that actually enables us to go to people where they are and spend time with them in, I'm going to say, a non-extractive way, because actually, there's quite a lot of the trust building is really about being with people in their space and meeting them where they are. So building these meaningful relationships, prioritise individuals and communities, both communities around our organisations, but also within our organisations, so recognising staff experience as well. Collecting and publishing data. This is absolutely critical. So all of our teams started by race or ethnicity. And this was not only difficult, but also really important. And not only important for identifying where issues were, but then also in tracking and monitoring progress against addressing those issues and those disparities. So identifying racial bias. So this is really about understanding how racism is embedded in them, which policies are written, which policies aren't written, who's been consulted on those policies. So really understanding how organisational culture is set through policies, through formal mechanisms such as formal policies, but also de facto policies. What's happening just because that's the way we do it. So really getting an understanding of those elements. Applying a race-critical lens, so really understanding who will benefit and who will be disadvantaged by interventions that are implemented. And then again, to that point about evaluation and reflection, really having in mind the idea that racism is a determinant of health for those reflections and evaluations. So, I have no idea, I've probably spoken too long, haven't I? Sorry. So the work is ongoing. The land teams continue with their projects. Some of the teams, and I'm going to say some of the teams have achieved. Some of the teams are still testing changes and working towards their aim statements. But what we are seeing and what is emerging is some of the positive impact of this work. So, for example, I'll just give you a few of these statements. This is from that teams have collected. So this is from a diabetes specialist midwife for one of the teams that's working on gestational diabetes. So prior to the RHO project, type 2 diabetes prevention was discussed antenatally, but there was no formal process to make sure information was understood and remembered. Working with the team has helped identify a reliable process. This has had minimal impact on our workload. So, I think this really hits a number of the really key points that we wanted. It's like, is this helpful for women? Is it easy for women? And is it easy or is it feasible? As recipient, this was from one of the projects that was around perinatal mental health, said, I felt supported and listened to. And, we see in one of the PPH projects, it's good that we have a system to prevent rather than to react. So the teams are continuing to work. We're working, as I said, with an evaluation part, contextual factors that enable effective change in this area. But there are some other things that we've identified via the teams that are kind of bigger structural or system-wide issues that really also need to be addressed. So what we're doing in the observatory is we're having a focus on some of those, how can we advocate and agitate for change in some of those areas. So I'll just talk briefly about a few of them. So the first one is, as we know, as budgets get squashed, the things that drop off, what we're doing is we published quite recently a briefing around the cost of racism, which kind of gave a high-level indication of some of the factors that are involved in or some of the costs of racism, so societal and economic and so on. What we're doing now is we're just working up a commission for a piece of work. In particular, we want to have a focus in that work on for maternal and neonatal services. So we want to be able to support practitioners to make an argument for the kind of work that we're advocating for this equity work, based on that financial argument, which is one that always comes up at the moment and probably forever. So co-production. Co-production's been a really core part. Co-production actually is not an easy thing to do. And so the teams have worked really hard in this land on how do they co-produce the work that they're doing. And there's some amazing work going on more widely. There's a gap around, some real clear guidance around how to do co-production effectively when you're working with minoritised communities and you want to address specifically ethnic health inequalities. So we're working up an invitation to tender for a piece of work to develop a resource associated with that. Ethnicity data, as I said, we all know about some of the challenges about the quality of ethnicity data and the availability of ethnicity data. And these are challenges that teams have found locally, and they've found some really amazing ways of kind of working around, and that's an advantage of quality data contemporaneous NHS England team and around ethnicity data and the programme of work that they've been developing around quality of ethnicity coding data. And then the final thing that I'll just touch briefly on is debiasing policies. So, this is, I kind of skipped over, kind of just whizzed over it as in principles. This is actually really, it's actually something that you need nations to develop a debiasing policy framework which will be specifically focused on ethnic inequalities. So we're doing, and that will be something that will sit under our toolkit for the anti-racism principles. Okay. I think that is everything that I needed to say. Absolutely loads of work going on across the observatory in many different areas. So maternity is a priority focus for us, but there are other foci as well. And so in working with us to develop some of the resources that support the embedding of anti-racism in the NHS, please do sign up. We just capture your details stuff, in which we'll connect people with others. It'll give you opportunities to engage with the observatory, and it's a kind of learning forum for sharing learning as well. So I think I'll show the time. Thank you very much. And the most important slide, of course, is I get the absolute privilege of talking about this work, and everyone claps and cheers, and it's amazing and wonderful. But actually, the people who are doing the real work are the teams. So we're working tirelessly. It's hard, and they're doing incredible work. So really, all the thanks go to them, but also thank to you for your attention.
Fantastic. So, no, that's fine. Stay. The Slido code, sorry, is 346. I don't know, computer, don't I? So we've got a couple of questions on there. First of all, we will share the slides, and feedback will be at the back of the conference brochure. It's a QR code. A question that's been put on the group: how are the members of the RHO selected, and how many are in the group?
So we had an open call. So we invited expressions of interest, and in fact, 10 teams expressed an interest, and all 10 of them, there was a process. We kind of asked them for, to submit some data and some ideas and some thoughts. They also, importantly, had to have an executive sponsor. So that's a really critical thing in this equity work, is having somebody who's at the top of the shop, who's really engaged and championing this work. So there's the second part of that question.
And how they select, how many people are in the LAN? How many are in the group?
And how many are in the group?
I think they may have been asking about the general RH.
There's like 15 of us. We've got, our board is bigger than our team, but we do have these incredible. So we have a maternal and neonatal health advisory, absolutely stellar individuals across that. So although we're a very little kind of team, the lever is through our kind of wider influence, our wider groups of advisory groups.
Brilliant, thank you. Let me just bring that up just before, and need to come up for to chair the next session. Remember where it is.
I've got a question for you. Where the tender for the co-production, is that for a tool or is that for a co-production?
So what we'd like to develop.
So there's the code, 3460146. Brilliant. I don't know. I think if you want to.
Manager, I'm going to co-chair this with Ed. I'm going to let Ed introduce himself.
Hi, I'm Ed Mullins. I'm an obstetrician here.
Lovely to meet you guys. And so this session is really, really important because this is really about the women that bring them around. We're going to invite each speaker to come and join us. And then at the end we'll do a panel and a Q&A. Okay? So I have great pleasure in inviting Agnes, which you know, I think, so much about already, or should know about it. I'm not going to put your hands up because I don't want to know if you don't know. Importantly, okay, her voice matters. Value-based healthcare is actually about the women. I'm afraid it's got nothing to do with health professionals and clinicians. It's all about the four of you who are going to talk today.
Thank you. First of all, hi everyone. It's been a really, really busy week because a lot of the work I now do bigger because usually I don't have luck. Right. And obviously you can all hear me back. So I'm Agnes Ajipong and I'm a kind of unlikely maternal health advocate and also clean air advocate. And like, who grows up in school? I'm going to advocate for women, or I'm going to advocate for clean air. It's not really something that I had in my kind of list of things that I wanted to do when I was in nursery and primary school and said, what do you want to do when you grow up? This is not how they look like this morning and so forth. But these are my three children, Ethan, Eli and Imara, and they're pretending they love each other. I think I'm very particular about these things. I'm a South East London born and raised mum of three, and I just want to make a positive impact in my community, to my children, whether that's on the school run. Quite a few things happen. So when I gave birth to my youngest child, who is the littlest one, but in my house he's the biggest one, because as you know, the little ones always are the cheekiest. It's definitely the case in my house. And so when I was pregnant, a bit of a backstory, so I'd given birth to my first child. When I gave birth to my second child, actually with UCLH, I literally went into hospital and within 45 minutes I was being whisked back out because he came so quickly. And so I was already warned that with my third child, I would probably not make it to hospital, right? Because I just gave birth so quick. And I know for a lot of people here, they might be like, oh, that's really great, you can have a home birth. But for me, it really give birth. And my children asked me for rights. I just knew. So actually getting to hospital and being successful in just giving birth and being able to have a minute with my child without being a mum to two other children felt like the dream. Part of the home birth team, and they were amazing. Like, I know about you guys before, they come to your house, they do all the checks. I made friends with a lot of the ladies. I was like, right, look, we're not playing around here. Let's get to the hospital. Like, I just want to make it to the hospital. I don't want to give birth in the taxi. And I need to get my bed. Like, that's all I cared about. And it changed for me. I had, as I said, an amazing experience. As soon as I got to the hospital, straight away, it was like, just sit down in the corner. Nobody wanted to listen to me. And we were like, have you looked at my notes? I dilate really quickly. It's a miracle I've even made it here. I'm just like, I'm here. For my first child, I didn't get to have my water birth because I was 15, and then I was like, where is everything else? Because I realised there wasn't a Blue Peter badge for anything. I just wanted whatever I could get. And so the pethidine, what happened was, because obviously it was still in my system as the baby was coming, I couldn't have my water birth. The second child, I was like, I'm going to have my water birth. We know what happened. 45 minutes later, I was in and out. So the third one, I was like, I'm going to get in my room and I'm going to have a water birth and it's going to be great. But now I wasn't listened to. I was just really, from the reception, straight away I was dismissed. And then when I had quite a lot of tension, I was then told I'm not in labour. Now, if you've already got two other children, trust and believe you do not step out of your house unless you know either a baby's coming out or an appendix has burst. There's one mission between my mum and making sure everything is okay. I'm not doing that. Something may be going on. With my first child, guilty, I did all of that. But by the time it's the third time, I'm going to be in and out. So I'm like, well, if I'm not in labour, then what is the pain? Like, it's either labour ward or A&E. But I just was completely not listened to. I was checked, I was told my even dilated, which straight away raised alarm bells for me because I had been in and out during that pregnancy to hospital, and I was already told that my cervix was 2 centimetres dilated. So the doctors that my baby had stayed in. So already now there was some alarm bells. And this is kind of contradictory to what I've been told because I've been coming in and out. I don't think I meant to say that. I said it in a nicer way, of course, I'm in labour. But what happened was then it became this kind of tension between me trying to advocate for myself and my children's father trying to like explain politely, but again, I'm in labour. And from there, I just lost it. I had a panic attack. I was like, I want my water birth, you know, I need my pain relief, like whatever you've got, you're telling me I'm not in labour. They had 3 different midwives who had come to check for me, but actually it was the student midwife who I managed to find again, and she came in, and I could kind of hear the 2 staff kind of talking about me. She's not in labour, she's just, you know, she's just here. You're 5 centimetres dilated, but, you know, baby's not going to come any. Your colleague just said I'm not dilated at all. So there was just all this tension. Anyway, long story short, I had a panic attack. That's where all those midwives were. I never saw them again. And so I was happy because I didn't listen. I did stay. Because I'm like, do I need to wait more seriously than that? Like, I just felt like I wasn't listened to. And if I had really listened to them and left the hospital, because literally it got to a stage where they were like, just an irate customer, basically. Just stay there. We're not talking to you anymore. We're going to deal with other patients. And so I was there for quite some time in pain, not being listened to, feeling really traumatized. And I always say, I was really happy. This was like 2018. I never knew that black women were 5 times more likely. I never knew we weren't listened to. I didn't know any of those stats. And I always say, I'm actually glad I didn't. But there's nothing like a mum with a bee in her bonnet, because as soon as that baby was delivered, I liken it to going to the restaurant and not complaining about your food until you get the food, because you don't know what they're going to do behind. So as soon as the baby was delivered and I was safe, no Jay-Z, that's literally what happened. And so there I was. As soon as morning happened, I was running around the for the matron, and if you know anything about having 3 children, like the contractions were killing me. I swore up and down they're twins, because obviously now with 3 children, the pain is it's like the uterus, the after pains felt like, if anyone's ever tried to have a third baby, let me not say, put it in your ear, but the after pain felt like I'm literally in labour all over again. If this could happen to me, then who else could this happen to? And it really became really important to me to be able to really humanise the patient, and that's when I learned about black women. I now became a mum with a bee in her bonnet, and I became a maternal health advocate, and it kind of eased in. So this was kind of a lot of work. So then COVID moved to hospital, and the doctors kept on saying to me, eliminate dairy, eliminate milk, eliminate, and I'm like, she's sick. During, not the 3rd visit, she was in a period of time, and on the 3rd time she was diagnosed with community-acquired pneumonia, which I found out at that time was one of the leading causes of death of children 5 years and under. Nobody had been listening to me, and we lived as air pollution listed as her cause of death. So we live in the same borough. So it was like all of these different aspects. So when I started becoming a Maternity Voices Partnership Chair, and I started being in a lot of these different meetings, I realised that this environmental lens as well was not being included in the conversation. A lot of our conversation around maternal health inequalities and inequities was around what actually had to be important. But actually, what are the environments that black and marginalised women are more like, that increases their likelihood of experiencing these inequalities? You don't just rock up in pregnancy. That doesn't happen, does it? All our hosts of all these other different, a lot of these different elements, it's usually underlining health issues which are not kind of present at that time. You don't really guess who they see, the midwives, who are not specialists in these different areas, and then midwives are then often blamed for missing these different cues and so forth. So again, this is me not taking away from a lot of the work that needs to be done around listening to black women in pain. I wasn't listened to, I know firsthand, but also I started finding out that there's a bigger, wider structural issue here that needs to end or begin when a woman's pregnant and now she's interacting with midwives. This is a public health issue, right? I have to always put this in here because I'm a beehive. But our voice, and actually using my voice and knowing that I don't need to wait to be a trained specialist and so forth, meant that when Beyonce did her Renaissance tour, we were one of 10 organisations that were honoured and awarded by important. Because for me, prior to my experiences, I always felt that, you needed to be like qualified or specialist in a certain type of way, right? And that's how your voice. I have a PhD studies in me, in living and being raised in South East London, in the experiences that I have, And no one can tell me otherwise. I don't need a report or data to tell me about Michelle, continuous victim of those circumstances, right? And so I set about, again, developing my own organisation, which initially was called Global Black Maternal Health, and it was about putting research back into the hands of black communities. I might not have all of those skills, but actually within my network, there are those skills. So you'll be hearing from Dr. Michelle Peter, who will be presenting later on. She's our head of research. You know, the previous speaker referenced 5 times more, so Chloe is one of our directors. Dr. Karen Joash is one of our directors. So what I did is I brought together a team of formidable individuals. When we're talking about research, this is really, really important because oftentimes, and I saw this myself even as an MVP chair and even prior to that, we are conduits to other people's research and research agendas. Even what needs to be asked, right, from the beginning, from the kind of iterative start, because what ends up happening is questions and hypotheses are already kind of put out there. Actually, when you really check it, actually that's probably what we shouldn't have been asking, or we're near there. But if we kind of move the dial, actually it would be a little bit more kind of specific, and then it would land more that was producing research, but not just. Again, it's really ironic because I don't actually like research, right? So imagine me, I'm producing research, but my mum says big mouth. So what that means is I like to back up what I'm saying, right? And so in order to back up what I'm saying, and I don't find the data that's out there, I need to produce the research in order to say, I told you so, right? So that is the implementation and the advocacy and being able to say, look, this is what women are saying. So one of our first reports was our Black Child Clean Air report, and that was linking into the focus is on hospitals and it's on midwifery care. And that's not to say that that is not an important part, but actually we need to be making sure that women are entering into pregnancy as healthy as can be. Like, to me, that needs to be the kind of be-all and the end-all. Why are black women disproportionately not entering into pregnancy the healthiest, right? So I thought Black Child Clean Air report, even things, we had our conference in Parliament last week, and our focus was on indoor air pollution. You know, pregnant women and children spend 97% of their time indoors, right? Important. But things like gas cookers, right? Things like mold and damp, right? Even when we're talking about the climate emergency, I always say, you know, how do you expect certain communities to actually think about whether the world's going to end in 100, like today? Right? So it's about reframing and looking at kind of epistemology and epistemic injustice about knowledge, what knowledge matters, and who's kind of putting that weight on different aspects of knowledge. For me, when I'm looking at things around clean air and the clean air movement, I'm looking at it from the lived experience of, well, I live in a very, like, you know, I don't like using those words, but through the kind of stats that they say, like, it's a very culturally diverse area with community, with power, with agency. But my pollution or what kind of clean air or structural inequalities looks like for me is that I have to go past on a main road, literally at the bottom of Old Kent Road. So even when I open the windows or my daughter opens the windows, it's very noisy. It's very, very, very loud. We've got the kind of in. And even when we did our report for our Black Child Clean Air, we had a mother who said, look, I have a newborn who was born early, but indoors there's mold and damp. But if we open, the electricity bills are being really, really high. I mean, they're still high. Right, let's stay there. But already just come out of NICU, breathing in the mold and damp. Do you open and then you're on a main road? But also, can you then afford to keep that? Talking about structural inequality, that's what it looks like. And so for me, it was really important that we started producing research and looking at these kind of wider social determinants of health as a way to tackle the black maternal health crisis. Because actually, we're just having healthier pregnancies, right? So bridging the gap, advocacy, access, and innovation. What needs to change in the wider system, and what should we be fighting for? So number one, community. You know, this is our Dr. Michelle that I was speaking about. I knew she was going to do that. You just came in when I was talking about our amazing team, and so collaborate, but not collaborating with us as conduits to a piece of research. Actually, when you're even thinking about playing around with an idea, come and stress test it with us, right? Let's see. This is something that I understand. It might be really important, but maybe that's at stage 2. Maybe at stage 1, this is the area of focus, right? Communicate. Like when we're talking about epistemic injustice, we're talking about knowledge and whose knowledge matters and who doesn't. of my name in order for me to be taken seriously. But actually, no, I didn't. I just needed to have grit. I needed to be able to assemble a team, and then actually just to be able to hold the fact that actually I do have some knowledge that is worth it, right? And I do have the ability to be able to bring people together. That's also a knowledge, a skill set, and that also matters, right? And that's a big word that everyone talks about now, like lived experience, lived experience. But it's not just like, oh, that happened to you. No, it's about ensuring that lived experience is equity in targets. So I used to be on the NHS Equity and Equality board for the maternity transformation programme. And it used to just amaze me, first of all, how different trusts and different areas, like the data is all over the place in terms of what is being collected. And we know that dependent on what is not collected isn't measured. That needs to change. There needs to be a kind of a systemic approach in how data is being collected. And I know how hard that is because I've sat on the other side and I'm no longer for different reasons. But measure also what matters, and then co-designing services, funding and collaboration, so equitable funding for grassroots groups in research and implementation. Engagement, it sounds like, okay, with lifestyle. Right? If I'm here right now as somebody who's now gone from being a kind of a patient to building my own organisation, and somebody is having a challenging time, they're not going to be between 9 and 5. Like, it doesn't work like that. I'm getting WhatsApp messages, I'm getting calls on Sundays, my team is also getting calls and so forth. This is a way of life. So then often what happens is then people come in and feel like they can just extract that knowledge as if it's, oh, well, you've just got those people. No, we need to be supported to be able to, first of all, do within the community, and we can be kind of bridges between that. But that comes with funding, right? If we're talking about really solving structural inequalities, and I'm just talking about it from a perspective, I haven't forgotten you, but a lot of the time, especially as women, and especially as black women, we're expected to hold and be this strong black woman and pillar for our communities. Then we're expected to work. Then we're expected to be the person who's helping around, and it's just expected that is what you're meant to do. And it leads to burnout, right? And I'm serious about solving some of these problems. Then women should women should be supported to be able to actually just focus on just this stuff. I can't tell you the amount of time and I come off the phone and I'm literally in a brain fog for the whole day because I just can't believe what I'm hearing. But I can't let them know that because they're breaking down to me, right? So even just factoring the fact that we are holding this in our nervous system, the trauma that a lot of people are experiencing, and we need to be able to be supported to do that. And so the collaboration then needs to be at the root.
Thank you, Agnes. Look, guys, every single speaker is phenomenal. So I'm going to put my head. They've got an appointment at 11. Totally understand. Thank you for agreeing. Okay. So that was Agnes. Okay. Now I've got Geeta. Okay. So I have great pleasure in inviting Geeta Nair, who's a senior associate solicitor at Irwin Mitchell, and a hands up for Irwin Mitchell because they're supporting our event today. And through her own lived experience, she's going to talk about what has gone through to her, how this has affected her, and the maternal safety aspect that she's going to deliver. I'm going to stop there and let Geeta come up because your bios and everything you can find on LinkedIn. Let's get the conversation going here because that's what we're really here for. So Geeta, over to you.
Thank you. Just me. Good morning, everyone, and thank you to Karen and the team for asking me to speak today. Just to add, my talk is not funny. That was a really hard act to follow, Agnes. Thank you very much. Equity is a civil right. That's a powerful phrase spoken by the amazing Dr. Karen Jerash. What I've been asked to share with you this morning is a journey. Those long-standing and stark statistics we all know about of disparities in maternal and neonatal care, a specific South Asian women, and the devastating long-term impact that ethnicity inequality in maternity care can have. My journey began 16 years ago, and I was 30, married, and excited to become a first-time mother. I had a normal pregnancy, attended all any first-time mother could be. What I didn't know, what no one had thought was significant enough to advise me of, was my own personal risk was up to 6 times greater of a 3rd or 4th degree tear. I went into labour on a Sunday. It was a busy teaching hospital. After several hours, it was clear I was not progressing as expected. There followed an evening change of staff, and that's when it started to deteriorate. It was just met with a brusque response. There was very little communication in the room. This went on for hours. When we did manage to we were talked about our concerns, I was actually told to stop making a fuss. We were ignored, we were patronised. The situation continued to deteriorate until you could imagine what happened. There was marked fetal distress, and there was several failed attempts at Von-2s, followed by quite a forceful forceps delivery that left my daughter Maya with deep laceration injuries to her face, and I sustained a 3C tear involving the entire length of the internal and external anal sphincter and nerve damage, traumatised by the experience. I was taken to theatre for several hours and then left alone on a postnatal ward. I was physically unable to even pick my daughter up to feed her. There was no one there to help me. I suffered my first episode of bowel incontinence the very next day, but I was actually just discharged without any follow-up in place. So from that first episode to now, I continue to be completely incontinent of feces and flatus, have marked fecal urgency, passive fecal incontinence, urinary incontinence, dyspareunia, and live in pretty much constant. We really struggled with feeding due to the injuries my daughter sustained, and we later discovered she had a fracture of the zygomatic arch. She also developed jaundice, but neither my health visitor nor GP were aware that it was hard to detect in her skin because it was darker colour. So by the time it was realised, we were rushed back into hospital, the same hospital, over the delivery on loop, and was helpers. He was really empathetic at my horrendous symptoms, but he never had any answers, and he never once suggested all the pathways, and that has changed, thank goodness. I did attend one appointment with Urogynae, and I was told to do pelvic floor exercises, despite my friends were all meeting in the park with their babies and doing normal activities. I was basically housebound. It was extremely isolating. Several months, I was eventually seen in a perineal trauma unit and underwent extensive endoanal investigations. And I was told for the first time just how serious my injuries were. Neuropathy, and my primary repair had completely failed, which is why my bowel incontinence was so severe. But it was actually a relief to finally understand why my symptoms. The years that followed were as far apart as I could possibly envisage them. I was, as I said, often housebound, trying to avoid the fear and the shame that comes with public bowel accidents. Stopped going out, and I was really just a shadow of myself. And that was despite having a supportive family, really supportive husband, who clearly had a degree of trauma himself. So since then, I've undergone further surgical repairs, tibial nerve stimulation, irrigation, medication, feedback, EMDR, the works. But I've simply had to adjust the way I live to cope. Now we come to the positive part of the journey. There is a positive part. 15, I was asked to start the start of the Mazik Foundation. It's the only charity that is dedicated to the support, prevention and treatment of women with OASI, obstetric have tears. Please do signpost them to the Mazik Foundation. So I started to share my experience to give other women a voice so we could work collaboratively to improve maternal outcomes. However, I was really mostly often the only South Asian woman talking about my experience and the taboo subjects at birth. And this lack of representation was also reflected in the support groups and the peer groups that I attended. And I constantly heard the same line from so many brilliant organisations I worked with. They wanted to help, but our communities were hard to reach. They didn't know how to reach out to our communities. During the years that followed, I sought to support outcomes or birth trauma, and whilst their injuries differed, so much was familiar as well. The cultural, language, structural barriers they faced with their care, and the impact injuries caused devastating long-term impacts. Their ability to socialise and work, physical intimacy, social isolation, economics of self-worth, and then the blame and the stigma that comes with things like incontinence. But the real turning point for me, my silver lining, was that 2 years ago, after being away from work for 50 years, I rejoined my firm Owen Mitchell and have been fully supported to continue my advocacy and my work campaigning for improved maternal outcomes. And we're so proud to be supporting this vital conference today. Taboos and to truly address the disparities in outcome, there needed to be a true collaboration between policymakers, healthcare providers, women's health charities. You can travel a lot further and a lot faster if you don't mind or care who gets the credit. Just work together collaboratively and all of us will benefit. And so I and my colleagues, including Anne Kavanagh, who's here today, spent 6 months organising the first South Asian Maternal Health Conference. There hadn't been one before. So the conference, and it was supported by grassroots organisations, about 20 women's health charities, including and other organisations, including the NHS Health and Race Observatory, ASAM, who are here today, British Sikh Nurses, and 5 times more. And there was representation from 30 eminent speakers, including Rani Thakur, Baroness Gohir, Nigat Tharif, and Professor Habib. Moving conference. It was about collectively the disparities in South Asian maternal healthcare and neonatal outcomes. The power throughout the day, including empowering South Asian women with accessible and community-led initiatives such as the Janamap. Earlier, the failure to recognise language difficulties is an overwhelmingly discriminatory factor which leads to a lack of informed consent, which we know a basic and fundamental right of every woman in childbirth. We wanted to ensure compassionate and culturally safe care for all South Asian mothers. And most important, we wanted the new government and NHS to recognise the disparities in outcome for South Asian women, including establishing an all-party parliamentary group on South. So if anyone here today would like to help collaborate or motivate their local MP to support the APPG, we would be so very grateful. The colour of your office, every maternity ward, and more importantly, included in every health policy, to use our collective power to ensure meaningful change and the next generation. Thanks very much for listening.
Here, so Peter, thank you for that. Guys, we're going to carry on and do Q's and A's later, but please use the Slido to put your question. I have great pleasure in inviting my friend and colleague, Nafisa. And Nafisa is a global campaigner for Southeast Asian midwifery, and she's going to tell you her story and journey and to explain how this matters. Over to you.
Thank you, Karen and team, for inviting me here today. It's a real honour and privilege to be here. And what led, what amazing people to follow. So, yeah. So, this session I'm going to look at, talk about what ASAM is, because many of you might not be aware of who we are, what we do and why we came, our stance on what we need to do to make sure, marginalised women, especially with my focus is South Asian women, what we need to make to embed cultural safety, inclusion and justice. Colleagues, they'd heard that I was going to be speaking at one of the RCM conference, and I don't know about you, but when I go to conferences, I always look to see if anyone looks like me, because more than often you don't see people that look like you. And my 2 co-directors, that's what they wanted to see. But unfortunately, we never got to meet for whatever reason. But we got in touch with each other, and we, as South Asians, we met in a restaurant in Birmingham, because that was central to the 3 of us. We started the conversation, and we were there 6 hours. ASAM was conceived, born, and between us there was about 30 years of sort of experience, and we could see from discussion that nothing had changed. The 2-tier system, as I call it, was ongoing from way back to where it is now. And we just felt we couldn't keep quiet anymore. We needed to say something, we needed to do something. So ASAM was conceived and born, and interestingly, there was a lady who was sitting on the next table, and we totally were oblivious to how we'd been spending in there. We were there 6 hours, and the lady, before she left, she said, I wasn't eavesdropping, I was just listening, but whatever you want to do it, because it sounds great. It was really, sort of a bit of a lift for us. So what we saw, so what began as a platform soon became, much bigger. And we began initially as a platform for South Asian midwives, but it expanded to support a wide range of ethnic groups. ASAM was born from lived experiences and an urgent need. for us to do something about the predicament within maternity services. And we know that South Asian women, as Geeta has said, face poorer maternity outcomes. To date, we are not just a professional organisation, we are a community-driven movement. So we came to experience avoidable harm during pregnancy or birth, and Geeta is a classic example there, as many as well. And also too many midwives from the global majority are unsupported, and we then again felt that we need to change this, and the way we wanted to change this was through advocacy, representation and education. The timeline of events. So our first meeting was in October 2019. We launched via Instagram. It was meant to be very small, and the first thing we did was we put out a call for it. We refreshed and relaunched in September, and we're still going strong. We are only 2, we're very small, but we say we're small but we're mighty. And you know, we work full time, and as Agnes said, it becomes part of your life, and you know, it's hard, but we do what we do. So what are our visions? So our visions are, we operate with a clear vision to uplift, to empower and amplify our community, and you need to get them both right to get that balance to be more effective. And our core values guide everything we do. We believe in integrity, we ensure every action aligns with our purpose. We believe that we need to be continually improving, so we constantly strive to do better for underrepresented communities. We are dialogue and mutual respect in all our interactions. And again, collaboration is the key, because it's about collaborating with those communities from the onset, not halfway through, where you're actually being with them with a blank sheet from the onset, and ensuring that you're consistent and have a wider impact. We did a call out, and these are just some of the statements that we received, for instance, and these are lived experiences, direct quotes. My first experience has traumatized me so much I can't cope to think about having another child. Or, why would you feel abandoned? We're meant to be caring for these women. I feel like I was treated quite unequally to the rest of the ladies. So, particularly from Pakistani and Bangladeshi heritage, face disproportionate risks in maternity care. Yet, many services still adopt a one-size-fits-all approach. Cultural needs, trauma, histories, and communication preferences are often overlooked. And, because of these high mortality rates within the South Asian community, and the underrepresentation of South Asian voices in maternity leadership, and also there's a definite lack of culturally appropriate care, and again, using advocacy, mentorship, and community engagement. Again, on the other side of the coin, from our workforce, these are some of the reasons why we believe ASAM is needed. It's about midwives' support, knowledge of events, networking. We know that those things, they are stuck at certain bands, they don't proceed. So we are that platform to support them, to meet and engage with like-minded backgrounds, and to join a network of other South Asian midwives. So, culture. What do we not talking about? Festivals or food, we mean beliefs, traditions, fears and preferences that actually shape how pregnancy and birth are experienced. Respecting these is not. Cultural awareness is not enough. True cultural safety involves reflecting on power dynamics, recognizing those biases that exist, and redesigning systems accordingly. It's not just about learning facts about communities, it's about working again in partnership with humility and accountability and respect. So some key to really consider when we are looking at cultural considerations and care models are, firstly, again, as I said earlier, you need to think about deeply influence how, for instance, South Asian women perceive pregnancy, perceive birth, and the postnatal period. Also about understanding that we need to respect cultural norms. For instance, practices around food, gender roles, pain expression, postpartum rituals. And, if we do this, it will build trust and improves outcomes. And again, one size does not fit all. South Asian communities are not homogeneous. We have to look at There's various religions within that South Asian umbrella, there's various languages, there's various socioeconomic factors, all shape the experiences that the community has. Culturally competent care must be personalised and responsive to individual needs, not based on assumptions. As I said earlier, representation does matter. We need a workforce that reflects the communities and satisfaction. Investing in diverse recruitment, leadership pathways and culture is essential and key. Again, another that should be focused on is that community-led collaborations. Services should not just for them. And we in Assam, we champion collaboration with grassroots organisations and work together. Culturally safe care grows from listening to lived experiences and incorporating them into the care models. It's very important to incorporate traditional practices such as confinement periods, spiritual beliefs, or these should all be acknowledged where safe and integrated and respected. And having open conversations around traditional practices will actually in behaviours and risk. Another area that is definitely important is challenging those structural inequalities. When you look at language and interpretation, beyond language interpreters, it requires actually tackling the institutional care. We know that South Asian women face increased risks during maternity because of these inequities. So care models must address both and social determinants of health. There's a big drive now, obviously, in digital and AI tools, but we have to remember that we need to look at how fit for purpose these will be for our communities, because there's a big chance of digital exclusion, and that will cause more harm than good. And they should be multilingual, accessible, and inclusive. Educating and upskilling the workforce is so important to be able to recognise, manage, and address issues regarding and relating to communities. That will give them a better sense of understanding. Diverse care can be given, and also understanding cultural trauma and its impact on care uptake. We also need mental health, reproductive health, and wider social support, because all these interconnect, and they are realities of women's lives, so it's very important to address and integrate those services. The final thing that I will say in relation to this is we must make sure no one is left behind, is the belief that it's really nice of her to say that. So, we support our workforce, and we lift lift each other up. Organisation into our workforce, we offer well-being. We believe that it's very important that our workforce has well-being, because they need a space, time out to rejuvenate, and we provide midwifery peer support. When we give peer support, we make sure that we are honest, empathetic, and we have great conversations amongst us. We do we do monthly wellbeing sessions in the evening from about 7. Everybody just talks about their week or their month, and if they've got any issues, and it generates good conversation, but it provides support as well, and we just facilitate the conversation. And sometimes by talking out loud, you actually know how to solve that problem. And then we sort of provide pastoral care, support, and we provide career mapping, because, as I said, our workforce from the global majority, they don't have the same opportunities as our white counterparts, and often it's in these areas. And we also update them on any project development, any member-led initiatives that are out there. So membership, we offer a paid membership for both midwives and student midwives and internationally recruited midwives, and continue our work. So these are some of the projects that we've been doing or been involved in. One of the first things that we did, and I said that we do a lot of collaboration, so we collaborated with Baila Dollars, and we organised through the Dark Lens conference. In fact, we've had 3. And we were very lucky that Owen Mitchell supported us in that. And we had 2 virtual and 1 face-to-face, and it was very successful. And we thought, you know, we wanted to celebrate black and brown excellence, because more than often we don't hear about the work that we do. And there is some great work that is happening, I mean, in this room that you know, black and brown colleagues are doing, and we showcased this, and it was very successful. We also collaborated with my dear colleague, Rohit Sagu, and we did the very first South Asian Nursing and Midwifery Conference in the UK. And it put together a report where we looked at, you know, what was needed to thrive and the experiences of ethnically marginalised midwifery professionals in the workplace. And we were very expecting that many to attend, but we had a total of about 80 midwives attend, and they completed the survey, and we put together this report. Another was the Not My Name campaign, because as a South Asian, throughout my career, my name has been shortened, has been anglicised. Oh, can we call you Naf, whatever. And in the early days, you just go on with it. But you know, a name is important. It's who you are. It's your identity. Just ask me how to pronounce it. I will tell you 10 times. Shorten it, because in many cultures it is important, and if you don't use a person's name appropriately, it makes them feel dismissed, it makes them undermined, you know, you're not respecting them. We're very lucky to receive funding from Florence Nightingale to do a welcome package for internives, and it was a 6-month programme providing them with pastoral care. So, you know, these midwives were coming from countries where maybe the system was different, and the transition is prepared. They come prepared with their skills and knowledge, but they don't come prepared to the transition. So it's about making them feel as part of a family, giving them that one-to-one support. It's like, you know, being in England, and sort of, you know, we buddy them up with someone so they have a point of contact. And I think it's been a very successful programme, and we've just had some further funding to continue with it. So we will be doing that. And also we've just received some funding to work with diabetes youth, some work with, and we did some work with Bliss as well. So that's just through the dark lens. And this is, we did an away day for our members, and our members to support them. And these are just the projects to date. We've done quite a lot of work, even though it's been a short while. And these are just some of our collaborators that we've been with. So, for instance, we need services that are responsive, not reactive. And this means ensuring, for instance, language interpretation, not leaving it to the risks involved with it. Time and time again, poor outcomes are related to language interpretations. It also means creating modesty-conscious birth, means having more South Asian midwives in leadership and cope with the most people affected. So, ASAM for me is a testament to the power of the community, and it has shown that what can happen if we centre compassion, culture and collaboration in our work. We are proud to stand for equity in maternity care and vision. Whether you're a midwife, student or someone passionate about equity in healthcare, there's a place for you in ASAM. So, you know, contact me later if you want to support or if you want to do anything. So it's about building a few people are respected, represented and supported. And, you know, a vital part of our mission is, again, to inspire more South Asian. It started out 25 years ago. I was the only one in my cohort, the only one in my area of work for a long, long time, and there still aren't enough, and we need represent that I can, you know, be that role model and be that sort of be that shimmer of hope that it's a great profession, and come and join us. And finally, so thank you. And just the final note, when we centre the needs of the most marginalised, we build a system that works better for everybody. Thank you.
Thank you, that was absolutely amazing. So just to remind you to continue to use the Slido. If you haven't got the code, just ask the person next to you. We're just uploading the sort of next set of slides. and we're just really pleased to invite two ladies who were giggling at the front row. And that's the lovely Chloe and Tineke. Just really want to honour them actually in that statistic. I know a lot of us felt the statistics and saw the statistic, but didn't really have the impact that they've been able to have and really driving through an awareness of how nations, the government, the RCOG, the RCM, and all of us actually being here.
Please come in.
Okay, fantastic. They're used to doing this, obviously. So, yeah, I'll just see if it's on my OneDrive as well. I can get it to upload.
Stand up and move a bit, guys.
Should we do it just a very quick stand up?
No, not compatible.
I've got Canva. I can sign on to Canva on here. Yeah, that might be the best one to do.
Yeah, do you want to do that? Yeah.
Okay.
Oh, yeah, then you do it.
Okay. Can I see my spelling?
Don't come and kill me today. I'm already not well. Okay. Emails. Do you have my emails? I'm sure it's Gmail. You know?
You'll be on your phone.
Let's double check.
Or get to do a magic link. Oh yeah, gmail.com.
How are you guys?
This journey was a journey
so far.
Girl,
Did you drive or did you
I took the train. I came after school and I was like, I'm on my way to code.
Yes, we are. So who are we? We are a women's health organisation that focuses on black men. There's 4 ways in which we do this, and staff and health professionals. A lot of the staff that we train from St Thomas Hospital, guys, we used to give them this badge, which I'm wearing now. We're going to see another poster on the badge. And it's to show women that they've been trained by 5 times more what to expect when you're expecting and who is who. So who is the health professionals and what to expect from that health professional. We also lobby the government. That's something that we do very, very well. And the reason why we started lobbying the government, because it's the only way you can create change is by going national. And then we do research and report. So we recently done our survey, which will be launched on the 21st of July. Hopefully you guys can all come to it. You coming? Yes. And this is some of the work that we do. So this video, before I play it, that was our first ever video when we started 5. But before I go into that, do you want to quickly talk about your story briefly?
Yeah, I can talk about my story. So one of the reasons why we started 5 times more is because in 2007, because it's a lot for me, but I'll give you kind of like the highlights. I realised, I kind of re-traumatise myself every single time, and I just keep going on and keep going on, and it's about that. But the highlights are essentially I was late diagnosed with preeclampsia, which led me to be induced, and essentially I wasn't believed when I told them I was in labour. Just having, it's not the end of the world, you know, loads of women have assisted deliveries and it's fine, but I just felt like it could have been avoided. I left that hospital, something's wrong, and I was being shut down every single time. One thing I will never forget is the look of shock on the midwife's face when my waters did indeed break, and she saw that I was 9 centimetres almost ready to push. And, you know, kind of the reason why we started, I was at the time, and still do, run Mums and Tea, which is like, we get together for mums, you know, get out the house, make a mummy friend, that kind of thing. Sorry, NCT. And yeah, I just found a lot of black women were having really, really terrible births, similar to my story. So through that, I stalked Chloe on social media, as she likes to say. I slid into her DMs, but for a good reason. Pregnancy, childbirth, and 6 weeks after, as you guys all know. And I was like, what's going on? And I said, let's do an event. Let's hold one event just to raise awareness because of what she did and because of, you know, the platform that I had. But I guess God had other plans. Here we are 6 years later, and we're going to talk to you about that journey.
So Tanuka reached out to me in May 2019, and then we ended up doing this video in July 2019. Is there volume? Can you hear the volume?
Can you hear it?
I don't know, wait. Yeah.
Black women in the UK Black women are 5 times more likely, and Asian women twice as likely to die in pregnancy and childbirth compared to white women. Why is this happening? Embrace suggested this inequality could be because of diabetes,
Call for action. Action needed to address these disparities. Policymakers, service planners, commissioners, service managers, all health professionals, what are you doing about it? We need your help to put an end to this. We can't do this alone.
What can you do? Help us share this video, sign the petition, have open and honest discussion about your lived experience.
If nothing gets done, will she be 10 times more likely to die?
And then that was our awareness and let women know what was going on. And at the time, we also had a petition on change.org.
Yeah.
That petition got shut down in December when the government, I think it was...
There's always something to do with the government.
Boris Johnson changed and there was something going on, so everything got shut down. So that means all the petitions closed.
Okay, and so we still pressed on. I'm not sure if you saw the first picture with a group of us. I was actually pregnant. I wasn't just a fat face. I was actually pregnant. I said I didn't absolutely want this to happen again. So instead of just, you know, making noise about the statistics, I really thought, what is a resource we can have to make sure that other black women are just not having terrible experiences giving birth? So to say stop, it was more like a stop sign as well as 5 times more. So it was like a 3-in-1, very handy. And yeah, we had a launch event at the Wing in November of 2019. And yeah, it went really successfally.
There's Agnes.
There's Agnes. Yeah, Agnes is in all the pictures. Yeah, and that was, I guess, one of the catalysts of knowing that actually this thing has legs and people are listening and people are telling. But we'll keep going. We'll keep going.
Why did I pause it?
Okay.
I can't pause.
They're a really good experience. Yay! I think, first of all, down to the fact that we have been campaigning and I took the steps on for myself. Beth, I'll never forget her, Jill. So lovely. But a few weeks after Floyd was murdered, and it feels like the whole of the world woke up and realised that black...
When the government opened up, we had to do another petition, which no one signed until George Floyd died.
Yeah.
That's when people realised, oh my God, this is going on. We had signatures. The longest time. And then once he died, we gained over 100,000 signatures within a week.
Yeah, and we ended that, the petition ended with 189,000 or something like that, signatures, which obviously led to Black Maternal Health being just taking you through a journey. So
we thought, oh my gosh, everyone is realising about black women, the work that we're doing. Let's create another video. As you can see, we like to create videos and campaigns. It gets people going. And so this is a video we did.
Agnes again.
As a black woman in the UK, I am 5 times more likely to die during pregnancy and childbirth in comparison to white women. We know the statistics, but we do. This is why we need your help. What can you do? Sign the petition. Take part in the 5 times more selfie. Share the information. Continuing to have these discussions. We cannot do this alone. We need your help. If nothing gets done now, will my daughter be 10 times in childbirth?
This brings back memory. This is why we're laughing, because oh my gosh, it's
like,
so dramatic.
Not happy about what's happened. It's just like having a video and then my daughter just pops up. It's so random, but it is true when my daughter's ready to give birth, if she chooses to, later on down the line. And the reason why I think we keep doing videos is because we want to create that connection. We want people to know who is behind 5 times more. We want people to see people that look like them on the other side. It builds that element of trust. So yeah, that's one of the reasons why we were so passionate about like just getting in front of a camera and raising awareness about it.
You talk about the petition? Yeah.
Oh yes, so it was 187,000. I can't say the rest of that number, but this is what we finished with, including once, I think in Parliament, obviously once you reach 10,000 signatures, you get a response. Once you reach 100,000, it gets debated. So it led to black maternal health being debated in Parliament for the first time ever. And that same petition gave some written and oral evidence in Parliament, and people were really interested in what we had to say, in our lived experience, and the fact that we have had such a huge community of black mothers that also supported us, as well as health professionals, which is good.
Okay. So then we launched our first ever UK Black Maternal Health Awareness Week. And the reason why was because of Delissa Park, who died and given birth to her daughter in a South East London hospital close to where myself and Tanuka live, both of us. Her sister contacted us when her birthday, which was 16th of September, we decided to launch the Awareness Week. And Awareness Week is about raising awareness on different things to do with maternity. So Delissa died from complications, something that could have been very much avoided. So usually we do things on disabled and pregnant, young mum, Muslim mums. We did an event on dads. Now we bring in neonatal care. We don't do it in September, but we do it in April. So September, we just keep it to celebrating Delissa's birthday and making sure we still raise awareness. And then September professionals and for partners. So we got groups of dads, and then we came together with the dads and asked them what would they like to know, what will help them during pregnancy and what would help their partner. Courses with RCOG, and came up with 5 steps for health professionals as well. The thing about us is we just don't want to scare women. We want to give them stuff to go for themselves, but we also want their partners to advocate for them.
And also I think the health professional steps were, we were just thinking, okay, we've got the women who have got their steps, partners also, professionals do, if they know about the stats, and how can they show that they support black women as well. Not that they wouldn't anyway, but what's another step that they can do to make sure that they know.
Okay, so Tanuka mentioned the debate. So when our petition went viral and gained over 186,000 signatures, it had to be 10,000, isn't it? It has to get debated. It took over a year to be debated. Other things like golf course being open during was debated before us. And the reason why our debate actually happened was because Belle mentioned her story. Belle, who's the MP, mentioned her story of her trauma, maternal health. At the time, Nadine Dorries, who's the one speaking, was the Minister of State for Health and Social Care. And also had a women's health strategy that they wanted to get responses from black women. So at our debate, she said women from black and other ethnic minority groups are underrepresented in the response we have received. That had nothing to do with our petition. We wanted to put a target to black women dying. So we've been asking for a target since 2020. 2021, we were still asking for that. And myself and Tanuka, we knew she was going to say it. We just knew they wasn't going to care. We decided to launch our first ever report 2 days later. first survey, not report, sorry, survey for black women. And that was us. We wanted to prove a point that black women do take part in surveys and they do respond. It just depends who is doing it and where the information is going to. Non-stop. We're just
I mean,
looking back now, like, wow. So I mentioned earlier with the training that we did in South East London, these are some health professionals that work at St Thomas's at the time. Nina on top, she no longer works for them anymore. We did the I Am Here to Learn training, which you can see they're all wearing their badge. And then we also launched the maternity colourful birth wallet, and it's a wallet that has instructions on women's wellness. It has we did start off with 5 recommended steps, where we added another one, so now it's 6. And on the wallet, on back and forth, it has information on when to seek the midwife, telling women to make sure they're up before you go and see a midwife, or if you have any concerns. And we've done that with King's Hospital.
okay, so I know it feels like it's non-stop. This is literally what it's like on our side as well. We're in August of 2021. We launched the all-party parliamentary group on Black maternal health with the help of obviously Belle Ribeiro Addy, who is an MP space for not only MPs to come and where members of like the NHS or different charities can come and give their updates and say what is actually going on with them, with their organisations, and how does it pertain to black women. So it's a good. We can never get anyone out of the room. Yeah. It's always a really good space, but it's also good. Like we've had so many people like Kate Brinkworth, Donald, yeah, people, yeah. So yes. It escapes me, but we're just very passionate about making sure that those impact, and another way that we try to change the stats. This led to the Black Maternal Health MP Pledge. So following on from the launch of our report, which was in, I think, April 2, we had a whole bunch of MPs signing the Black Maternal Health, I think 3 or 5 actions that they can do in their... 4.
And one of the main ones was put a target to black women.
Yeah.
So we're still asking for the same thing.
Yeah.
So this is 2 years, 22, we're still campaigning, we're still supporting women, we're still training, we're still coming out with new things for women. And it's an app. And on the app, you have videos of health professionals, Karen's on there as well, talking about all things relating to pregnancy, to connect with each other. So we wanted to build a community, so on the app to each other and connect with each other. And we have dilemmas, and we also have our free resources, and it's free to download, and it's for all women, so all women can download the app.
We also hold regular brunches. So for me, I feel like, no offense, but when some children's centres and health clinics and stuff like that can be really stuffy and a little bit clinical, and we really wanted to come and to discuss with one another and to learn from one another. So we have regular brunches to connect with our community, with pregnant mums and mums who have had babies in the last 2 years. They're always a hit. Free food, why not? But it is honestly just a great place for mums to come. The last one we had was in Black Baby Loss Awareness Week, and we actually did something called a rainbow brunch, which was for women who had experienced a loss but are now either currently pregnant or have had a baby, and saying that sometimes when they go to the normal spaces, they feel like they can't talk about their loss, but when they are in the baby loss spaces themselves, because they've now kind of moved there. So we wanted to give them a space where other people can understand where they're coming from, and so they can connect with one another. And it was a real success, actually. We got some really good feedback on that. Yeah. Last but not least, Michelle's been working really, really hard over there on the team. Woo woo! But we will be launching the next iteration of the Black Maternity Experiences report. Now, the last one we launched was and we wanted to find out what was going on behind the statistics, but we don't actually know about the morbidity and the illnesses and the serious things that happen. It's not recorded anywhere. We know about are complaining, but it doesn't seem to be going anywhere as well. So what exactly is going on? How can we speak to those women and know what their experiences are like giving birth? So that will be anyone who's had birth. Problems to have. Yeah, we'll definitely be keeping everyone up. In here would have heard, you know, if you're not maybe not clinical, you probably would have. Making sure that we're bringing it to the forefront means that change can continuously happen, because if it's here today and gone tomorrow, my daughter's still going to be campaigning about this. So there we go. Want to read the question?
Thank you both very much. Can I invite the speakers, the 4 speakers from this session, do you mind coming on up and standing at the front? We're going to fire some questions at you.
Okay.
I'd like... Yeah, thank you. Thank you so much for all of your talks this morning. We've got some questions from the audience for you, so I'm just going to start going through these from Slido. 5 times more, are you planning to expand your training center?
Plans to take it digitally, which will make, you know, so we don't have to be there every day. Oh, thank you. So we don't have to physically. So nice in person. Yeah. I know, but it's we would
South Asian Maternal Health Conference this year or next?
Yes, there is.
Yes.
So we wanted actions and outcomes from the first one, not just do a conference for the sake of it. So we're really trying to push for the All Parts Parliamentary Group for South Asian women, structural barriers and systemic issues before the women get to hospital. So yeah, we're looking to do the next conference. It will be in spring 2026 in Birmingham. We'll take it out of London. We'd love to have you. It's all about collaborators and allies. So yeah, please do come along.
Super, thank you. And this one I think is for Nafisa. Big question though. What's the most common issue faced by South Asian women that everyone needs to learn as a healthcare professional?
The assumptions. Assumptions, the age training. But I will say, we're not just princesses, we're queens. So we are.
Small question, this one. In a society which is built on inequality, how are any of the changes going to be effective?
Repeat that again.
Society built on inequality, how are any of the changes that we want to see going to be effective?
Well, I think we can't just be looking at the issues that we see in maternal health as just maternal health. We need to change. So we all come from society, right? And so if we're just looking at one aspect, which is maternity care or women's birthing experiences, it's embedded into housing, it's embedded into education, it's a structural inequality, it's a public health issue. And so really it's about how to reach a lot more louder, so it's not just kind of reaching the doors of just midwifery and maternity care.
And asked to fix a lot of society's ills in maternity. But it's just the first time we've noticed them.
Exactly.
Yeah, good question here. So in terms of the groups that you're for this sort of work compared to Insight?
Well, I mean, that's one of the reasons we're taking the conference to Birmingham, because actually there is fantastic work. I mean, Birmingham's super diverse city, you know, there's amazing grassroots work, but part of the conference will be about bringing those giving a platform to the grassroots so they can collaborate and meet with the bigger organisations and work going on regionally, nationally. It's about giving those organisations a platform so that they can share their work.
And I think that's also inequalities here, is because usually it's the same voices that we hear in the room, and there's a lot of people that are actually doing the work on the ground, and they're doing it because that work matters. They're not doing it for the publicity or from socials, and it's those people that we often don't hear from. And so, you know, especially if we're doing the most work. But what we always find, and something that we always say, is that, like, I've got Abigail here right now because social media is a job. Like, it is to be doing all of that. Oftentimes you're just not doing the work, right? And that's what we found. So it's about really ensuring, it's about really where we place emphasis. I just saw you on TikTok, so you're doing all this work, or are we placing emphasis on the actual outcomes? And actually a lot of the community leaders who are just doing amazing work. And what you're saying about going to Birmingham, I know I've spoken to 5 times more of the work that they want to do now is actually taking it outside of London, going to Wales, going to Scotland, and different places. Because what we're finding is that it's becoming a popularity contest as opposed to an actual impact contest, right? And so that's really, really important.
Very well said.
Can we add Belfast as well?
Brilliant. Are there any questions from the room? Paula?
Are any of you trying to grow as an
My daughter is. My daughter is.
Can you imagine we are in the news every day?
Can you repeat the question, please?
I'm sorry. I asked, are any of them planning to run for members of they need to be in the parliament?
I'll be trying to.
So, yeah, and I think it's about inspiring the next generation, and I was just saying that actually from the work that I've been doing, actually my daughter heard me for the first time speak in the House of Commons a couple of weeks ago, and you know, it moved her to tears. She knows the stories about her, but she's never heard me speak, and she's actually now...
I think it's not about us, we are just leading the way, as Ita and everybody rightly says. It's about giving the tools, giving that hope to the next generation.
I've got a question for you.
No, I was going to say...
Yeah, it was a complete...
We kind of already do. So as I said before, Chloe is a director. The work that we do work also around Senate equity. Tanuki has been heavily involved. Both of them in each other's DMs. So it's just to say that even though it might not be, again, publicly seen, we're not siloed. This work is not about personality or popularity, but it's about the work, ideas and insights on the phone, wherever we need to be. And I know that if anybody here or within the room was doing something, we always say we just take our position. If we need to be the cleaner at that conference, we're the cleaner. If we now need to speak, we speak. We do whatever we need to do to ensure that the work is going to be done. So yeah, that's basically how it works.
That I recognise, if you don't know me, Google, no, I'm joking. No, right. So there's a lot of people that I recognise in this room, and I think some of us get really, really tired over and over again. And how do you put through that and still do all the work you're doing? I do it too, but I think we all need like a little boost.
Can I just be completely honest? I'm just a very honest person. I woke up this morning with a very, very terrible headache, toothache, period pain, had a school run, and I had to travel an hour and a half. Thank you, Karen. To get here, so I was late. You can imagine just like, you know, like getting up and just, oh my God. And I was on the train, listening to my music, and this woman came on the train, she was pregnant, and no one got up for her. Black woman, no one got up for her. I watched as every single person looked up and took her number. And when I leave here today, I'm going to send her some resources. And I feel like it was a good reminder, thank you. It was a good reminder of my why. Yes. I do it for the women like her. I do it for the women who may have not have heard of 5 times more and potentially not even know what the risks are. But now she's aware, she can advocate for herself with, all of that kind of thing. And for me, that's what keeps me going. But also putting boundaries in place. Today, I quite honestly said that I'm not going to sit here and rehash my story and my trauma. And it's
An applause, and then coffee and back at 2:45.
interviewing parents, finding out what their perspectives are, what their experiences are, and also speaking to healthcare professionals as well to find out what it's like to deliver that kind of service to families. My interest though is in maternal health techniques that we see, racial inequalities specifically. And I'm really keen to know how we can offer equitable care to support the needs of the diverse families that come through the healthcare system. So thinking about prenatal genetic tests, when we're communicating about prenatal testing, when we're thinking about kind of what prenatal testing is, it's complex. We have a very increasingly diverse population, and with that there are many factors that need to be considered that parents are coming to these appointments with when they are being offered these tests. So we need to take into account their cultural beliefs, their religious beliefs, their own personal values, often the beliefs of their family, and their prior experience as well. It's really understand that all of these influences are really important to these families, and that it's important that healthcare professionals demonstrate not just kind of cultural sensitivity. And I'm really glad that kind of talked about this before and set the groundwork really, but it's not just about cultural sensitivity, but also this ongoing process of cultural humility when you're offering these kind of tests to families. There's a difference between the two. Yes, they're related, but they're also distinct concepts as well. So cultural sensitivity is more that you acknowledge and understand that there are differences, that other different cultural customs, traditions, beliefs that are different from your own, but equally that you understand that they're not just one thing. Cultural humility on that, self-reflection, of learning, of understanding, of curiosity. It's definitely about understanding that you don't know all the answers. You're obviously not expected to be an expert in every person's culture, these things, and it means you can address health inequalities and you can work collaboratively with the patients that you see. So I'm going to draw through this talk. I'm going to talk about 3 different projects that I've worked on. I've drawn okay, sorry. A couple of years ago, which is called the Express Study, and that was a study that looked at the evaluation of prenatal exome sequences, a particular type of genetic test for in pregnancy. Also going to draw on some findings from a study that I did with South Asian parents and Black parents as well. I conducted some focus groups, trying to understand what people add on prenatal testing. This is a paper that we had published earlier this year. Rachel, she's here, she's somewhere, she's out there talking, but she was integral to this work as well. Rachel Barber, someone will stay out. And I'm also going to draw on current work I'm doing, which is focusing specifically on the experiences of Black women who have been offered further invasive testing or screening during pregnancy. And so these are some of the quotes from these interviews that I'm going to use to talk about cultural sensitivity and cultural humility involved in these tests. So the first thing is, when we're thinking about cultural sensitivity, we need to think about the fact that we're trying to communicate often really complex information about genetic tests to people sometimes whose first language isn't English. Genetics and genomics is really quite tricky. It's difficult for people to understand. It can be tricky to understand even if your first language is English. And as has been said already, every parent deserves the right to fully understand what their prenatal testing options are so that they can make informed choices. Stressful, anxiety-inducing time. I've just found out potentially that their child has a genetic diagnosis. You don't know what the outcome of that is going to be. So what are some of the problems that might arise? You might find that parents whose first language isn't English might agree.
Bridge between families and between healthcare professionals. But I think what's critical, and I saw this in a paper, 2023, is that, it's cut off, sorry. But many maternity services don't actually record a woman's need as available. So it's good in theory, but in practice there are some issues that we need to be mindful of. So for instance, trying to access interpreter services in a timely manner when you're under time pressures. And this is an example from a fetal medicine consultant that I interviewed. And she said, you can have a list in fetal medicine where you've got an Arabic-speaking lady, Pashtun-speaking lady, and they convey genetic testing, especially exome sequencing. So you've got the practical difficulties of trying to arrange interpreter services when you have a clinic list that's got people with multiple different language needs. To rely on family members to translate in the moment. And I've spoken to clinicians and they feel really uncomfortable about having to do this. but sometimes that is the only way when they haven't been able to access an interpreter. And I do worry that things might get left out or misconstrued. And so we know with family members, they can unintentionally filter information that's coming through, or intentionally, actually, and leave out important details, or they can oversimplify. A lot of the healthcare professionals that I've spoken to, who have a consultant who told me it's a situation basically where the mum was saying, and she said, I had a lady last week to consent, and I was lucky because mum understood me but couldn't speak very good English. The interpreter started and mum interrupted and said, she's not saying the same as you. And basically the interpreter had just said, oh, the baby's... What you get is potentially people getting falsely reassured because they've been told the wrong thing. Potentially they are becoming more anxious because they have... And then you've got people then who do not have English as their first language being denied that same level of autonomy as someone who can speak English. So ultimately, you accurately note down parents' language needs, as we said, that isn't done robustly. Book interpreters in advance. Ensure that interpreters have genetic knowledge. I think this is really tricky because I just think the bank of interpreters makes this very difficult, and I think actually maybe that's something we need to focus on, is making sure that there are, and not just within genetics actually, just clinically in general, that there is upskilling of interpreters. And also you can use appropriate materials to guide those conversations. Another thing is that with genetics, it's full of complex terms and acronyms, actually not even just in genetics, in maternity care in general. So in genetics, you might talk about a CVS or you might talk about NIPT, and a lot of the time, families are just overwhelmed. They don't know what it is that you're talking about, and it can alienate parents who are unfamiliar with our healthcare system. And we want people to be able to make informed decisions, and they can't do that if you are using all of this medical jargon. So I'm going to give a nice example, because I feel like whenever I write these talks, I'm always just giving an example of, this was a Nigerian mother that I interviewed, and she had not long come over to England, and she described how she had, the clinicians were really patient with her, and answering all of them that the clinicians were really patient. So it's a nice example of them acknowledging the additional questions that she had related to her not really understanding what the healthcare system is like. But equally, we have experiences like this one. This is a Bangladeshi mum that I interviewed, whose first language was not English, and she talks about the midwife had called her up basically and told her that she had to use the baby's, is it baby's blood or is it my blood? And then there was that one with 100% accuracy, but you have a 1% chance of miscarriage, and she said she did explain it, but I wasn't quite sure what she was saying. So you've got this situation where she's being bombarded with information, English isn't her first language, she doesn't really know what's being said, and the midwife had to check that she's understood. So in terms of bad parents, seek clarification if they're confused. Not all parents will ask you if they're confused because they feel embarrassed, or they feel this deference to authority where they feel like they can't question what you're saying. There's also the temptation to ask that parent, can you tell me what you've understood about what I've said? Get them to repeat it back to you so you can see if they've understood. And give people that time and that space to ask about respecting people's cultural and religious beliefs. And with prenatal testing specifically, a lot of the time it can represent deeper values. So there are beliefs about the sanctity of life, there are beliefs about it must be guided by faith as opposed to what they might consider medical facts. Particularly with invasive prenatal testing, so whether you have amnio or CVS, there's a small chance of miscarriage, and that can be really worrying for some families. You want to know, wouldn't you like to know? But for other people, there is a prioritisation, particularly in some spiritual frameworks, for preserving life over having this certainty about whether their baby has a genetic diagnosis or not. In Muslim communities, and this is, again, I don't want to generalise in all communities, but in some 120 days, there's a strong emphasis on accepting kind of what God's given you, accepting your portion. But this is an example here of where I think whether she should accept testing or not. She said, I went around trying to get information from my local imam. Every single one had a different opinion. That's another thing as well, is that different schools of thought have different opinions about it. And so this is where it's important to understand that cultural sensitivity, yes, can help you understand different communities have different views and different traditions, but it's not a blanket rule. I feel like as humans we like to put people into categories, but that doesn't mean that every person that you've seen who in the past who looks like this has done this, so this is what all of these people will do. One testing when you kind of ignore the complexity of people's individual beliefs. So in terms of the things that we don't want to do is making these stereotypical assumptions, so clinicians saying things like, oh, you probably wouldn't want risk, because obviously the risk of miscarriage, I think, is it 0.5? 0.5, so 1 in 200, and that's big enough for some families. That is completely big enough, especially if it's been a wanted pregnancy, especially if it's an IVF pregnancy. And so this is where it's important to engage in what I'm talking about, culturalness, where you understand the why behind people's choices, even if it differs from this kind of dominant medical model of wanting to know everything. In diagnostic tests, as I said, it's really complex, lots of ethical questions, can lead to difficult decisions around whether you're going to keep your pregnancy, so termination, whether you want further testing and risk your pregnancy. Do you want to raise a child who might potentially have a disability? Lots of ethical considerations that, for many people, they want that decision making to be a shared process, and particularly within in South Asian cultures, family involvement is common. The same with some African cultures where community elders and the view of community elders is critical. And so this is an example of an Indian mother that I spoke to, and she basically gone to her appointment. She's gone on her own. And she said, I went on my own, my husband couldn't make it because he was at work. And she explained, when she says she means the midwife. She explained to me, my option told her that I wanted to speak to my husband about it. But she said it was my choice. She said that a few times, yeah, I don't know what she meant by that. And I think this is a good example of where autonomy is the same across all cultures. So across all healthcare systems, across all models of care, I think in the West, we have this prioritisation of you should be independently making your own decision. You don't need to ask anybody else. But in some communities, that process of making a decision with your family, with other people around, autonomy. And I think that, and maybe people I'm wrong, but it can feel uncomfortable when a parent is reluctant to make a decision without first consulting someone else. This is an example from a midwife. She said, I do worry sometimes when I'm talking to a woman and she's sitting there being quiet, looking at her mother, if they call the shots, or if that's just the dynamic they have in their relationship. It can be really hard to get across to her that it's her choice, it's her body, so it's up to her at the end of the day. I think it's really important, I guess it's important to be mindful of coercion and external influences. You need to be aware of that, but equally I think you can unintentionally misinterpret what are very culturally appropriate choices. So, this has all moved up, I'm really sorry. So instead of kind of assuming that the family are a barrier and you don't want them to be involved, actually what you could do in the conversation, make that space and make that time for them to be part of the conversation. I'm really sorry if you're taking photos. All the formatting's gone wrong. Assuming individual autonomy is the sole priority is not what we want to do. You need to be members. Allow time and offer follow-up appointments so that other family members can come and give their views, and also asking open-ended questions. This is where this kind of curiosity comes into play, but still means that you are trying to find out about what that decision-making process is like for that family. Another one, and I think this is probably like one of the biggest ones, is acknowledging it is due to a history of discrimination, unequal treatment and medical exploitation. And I've given some examples here of the Tuskegee syphilis study, for instance, of Henrietta Lacks, of John Sims. If you don't know those studies, those people, I would urge you to go and find out about them just for your own sake. But just briefly, the Tuskegee syphilis study happened between the 30s and 70s, where black men, African American men, who had treated for their syphilis, but they were actually given a placebo. And there was no informed consent as far as we are aware. And even when treatment for syphilis became available later on, towards the end of the study in the 70s, they were not given it. So a complete violation of ethical law, stolen without her consent to study cancer. And John Sims, who performed kind of gynecological procedures on female black slaves without anaesthesia. So you've got a long history of, what we all know anyway, is that mistrust doesn't relate to historic events. It's also relevant to all of the stuff that we've talked about today. We know that maternal mortality and morbidity is higher for black and Asian. We know that just actual experiences are worse for people from certain populations. So people are coming to these appointments with all of this baggage with them. And so sometimes this mistrust can show up in different ways. Sometimes it can be about mistrust in the accuracy of the test. So this is an interview that I did with a Bangladeshi mum, and she said she declined synthesis, and when she's born there's no problem, alhamdulillah, she's now a normal girl. So that's what happens. Sometimes it's wrong. So that's why I'm scared about those tests. That's why I didn't agree. So she didn't agree to a test because her friend basically got a false positive result from a test, and she decided, well, the tests aren't accurate, they're not good, they're not fit for purpose, I'm not going to do it. Sometimes that mistrust can be about how you're going to be treated, what are the intentions of the clinicians. this mother that I spoke to, she said, my grandma said I'm going to be used as a guinea pig because she's got her own perceptions of the hospital, things that were done to her in the 80s. And that's why I chose not to have the test. So she spoke to her family and she just didn't have a test. Sometimes it might be about how your community have been treated in the period very recently. And she said black people being tested for certain drugs, tested for vaccines, not being treated as equal. And it can also be about worries about how you're going to be perceived. So this mother said, you might not necessarily push as hard as you want to. So she's talking in the context of in her looking as if she was aggressive, essentially, because you don't want everyone to look at your antenatal notes and think, oh, this is going to be a problem patient. So essentially, mistrust can lead patients to decline testing because they might think you've got a hidden agenda. They might worry that the results that you get from these tests are then going to be used against them. So for immigration, for child welfare involvement, all sorts of reasons that people really genuinely fear having these kind of genetic tests. And they might avoid asking questions or engaging with you in the first place just because they don't feel safe or they don't feel respected. So bad practice would be assuming that everyone starts from this same level of trust, and also a defensiveness, actually, like, don't you trust me? But I think it's really important to understand it's not about you, the individual in front of them, it's about you, as in you represent the system. And so supportive practice would be inviting that reflection, asking these open questions. Have you had a test like this before? How did it go for you? Exploring what their concerns are. So are there anything with ancestry from Africa, from the Caribbean? So if you offer screening for sickle cell as a maternity healthcare professional, that's appropriate. That's obvious that you need to do that. But how you do that is for a high chance screening result. But she declined having invasive testing for sickle cell. And she said, it was one of the most I had at that hospital. And she was just very, very mean. And the tone of her voice changed. And she said to me, I remember exactly what she said, bring a sick test, because she'd had a high chance result from her screening. But she was also offered to have testing for sickle cell at the same time. And she said no. So for her, it wasn't about this and everything. I just wasn't expecting to go through that. I don't think it should be viewed as a burden. People can't help what they're born with. So yeah, I felt a little bit annoyed that medical professionals were kind of coming with that viewpoint. And I've got tons I can't go through them all, but I've spoken to for time. And so obviously, using fear to steer parents towards a decision is bad practice. Assuming that all black patients who you offer sickle cell screening to one list. Obviously, none of those things are going to support any parent who's having to make these kind of really difficult decisions about prenatal testing. Like no parent, but who come from different cultural, ethnic and religious backgrounds. The reasons for this are that they create inequities, they exacerbate inequities in care. So if parents agree to procedures they don't fully understand because they've got a language barrier, they don't have English as their first language, that has a disproportionate impact on immigrant, non-English speaking families. If parents feel pressurised into accepting tests that they don't and finding out what people's perspectives are, it's not about knowing everything about everyone's culture, it's about asking and learning without judgment. And if you do that, then you can provide respectful and impactful action for research, because I am a researcher, to make sure that we include the voices of people from underserved communities so that we can understand how to operate with cultural sensitivity and cultural humility. A lot of the reasons that I'm able to say these things is because I've spoken to women, I've interviewed them.
That is from what she said. So just hold that, okay? So we flipped the presentations round because you needed to hear this. And then we're going to have a 10-minute panel discussion. I seem to be the bearer of delaying your coffee and your lunch, but I think, let's be honest, you know, let's half
here we go.
the slides, yeah. Almost, no, don't worry, I got it. Got it.
Yeah.
You got it.
Excellent. So over to you, Ed.
Hi everybody, might affect the change we want to see, especially if we want to move away from simply the problem. So my research starts to try and use the data that we collect every day in clinical practice, so like Saving Babies' Lives Care Bundle are actually doing what we think it does. And we can start to use those also to start to deliver research projects. So, you know, I could recruit a woman into a study, really excited about this big data, and you go off and you have a look at it. And unfortunately what it looks like is this. Now, that's not because people aren't trying and they're not necessarily collecting the right things, and we're always adding to the data that we're collecting. But when you get to try and put all of the data together, so maternity data, with neonatal data, with administrative data, you know, what's the educational outcome women need for her pelvic floor health 10 years down the line? It gets pretty tricky to try and put it all together. What I'm going to talk you through now is some of the things that we are doing to try and use this data, not to use the data there. So this is what I'm going to tell you about in the next 9 minutes. What do we collect? How good are they? What are they used for at the moment? And what important questions should we ask using the data that we collect on pregnancy? And as you can see, it's this sort of whole patchwork and mishmash of different things as women go through their lives. Previous pregnancies, preconception, encounters with hospitals, maternity services, as they go through the pregnancy, and then looking at later life health and child health. Alongside all of that, underneath, you've got all the exposures. So we talked about air quality today, all of the things. So all slightly different, not all terrifically interoperable. And generally what you get across the UK is the outcomes of pregnancy. So once the pregnancy finishes, then the data gets submitted. And in the UK, the neonatal unit clean it up because it's been put in by frontline clinicians, make sure it's good quality, and they're avoiding the rubbish in, rubbish out problems. Neonatal data is collected by perhaps only 3 information systems, Badgernet, Cerner and Epic. You've probably used those sorts of things before, and then they get funneled through and put out ready for use. This same place or has care in the same place. If you follow women who are planning pregnancy through, does anybody know what proportion of pregnancies end in miscarriage? Pregnancies end in early pregnancy loss. So this is an awful lot of experience that we're not capturing at the moment. So routine data at the moment can't do this. So you need something else if you want to look at early pregnancy statistics or CPRD data. Up in Scotland, they collect maternity data at the start, at booking, and at the end as well. That's different to vaccination and who needed adjustments to their care. So that sort of routine data can be very useful too. So how good are the data sets that we've got? And I'm just going to so the maternity services data set started in about 2015, and over time it had a number of what's called things that you had to put your data in from your hospital and submit, and non-mandatory fields. And of the ones that are mandatory, it's matured over time. So increasingly the data is of better and better quality. We're looking at here at gestation length of birth. That's quite a simple one. How many weeks were you when you delivered? That's up closer to 100%. Encouragingly, ethnicity category is pretty good too. In that, we know that the data is going to be reasonably complete. We don't know how good quality the input was, but we know that at least it's complete for most of the babies. When you look at non-missing data, so are you going to assume that the people who didn't have the data put in were the same as all the rest, or are you going to try and exclude them? What are you going to do with it? So you have to decide how to use missing data carefully when you're using routine data. And then you say, well, which one of these am I going to use? MSDS or hospital episode statistics? MSDS started off in 2015 and it's had a version here is the percentages of births which were captured in our maternity services data compared to those that were captured in hospital episode statistics. It's mind-blowing that they're not the same, but they're not. So in our maternity services data set. And then it got better as people got used to using the data set, and then they changed it. And then it got worse again, so it's less than 60%. But now you can see that encouragingly nearly 96%. In terms of how useful each particular one is, essentially hospital episode statistics is a bit more outline, so it just going on. So a team between Southampton and UCL does what's called a preconception scorecard using maternity services data set. At the booking appointment, you're finding out questions about how well planned pregnancy, whether they're using contraception, and that starts to give you information that you can use to support public health programs. So you can help women in different groups to prepare for pregnancy better. Because we all know that pre-pregnancy outcomes, and they collect data on ethnicity, different social deprivations, and English not as first language. So that's really useful. It's also used to publish in The Lancet, and this used hospital episode statistics. But the trouble with these sorts of things is that you're getting 2018-19 data that's published in 2022. You know, we had the COVID pandemic, we've had things. But these papers were really useful, and they give information. This one here is on stillbirth. The left-hand bars are by increasing social, it shouldn't be used. But we're always very careful about privacy breaches, so there are very careful processes to protect people's information. The discrimination and stigma of using that data to describe group. So what I think this should be is a part of healthcare. I think we should be using routine data as a continuous audit tool for our services to evaluate, service, improve routine data. So you can do big, what are called step-wedged cluster randomised trials where you change practice in hospitals over time and see what the differences are. We've already got an exemplar with the way that they're doing this already. So, they also use it for evaluating service change. The neonatal data is actually the data that gets used for our national pregnancy and diabetes. Then it drives sort of national policy research as well. It's been used to deliver randomised trials. So you can say for a whole hospital, we're going to withdraw enteral feeds, which we're cleaning up at the moment. And my vision here is to make this open access and available to use for the researchers and to organisations that want to have to clean it up first to make sure it's good quality.
If you both want to stand there, we'll just hand you the mic. Just going to bring up the Slido. So just go back onto your Slido. There are a few questions on there, but they were brilliant talks, weren't they? When you really look at the data, what it can show you. I'm so excited. I was like, Ed is like my little brother, by the way, you guys. I'm sorry, I thought I should declare that, but seriously, like my little brother. But I didn't even realise that. I know you talk about data all the time, but that's fantastic. I've been listening in between talking about.
Some of that myself. What you can do, I think, that can potentially reduce the costs is work with a community advocate. So in the work that I talked about, Lily Islam works in Spitalfields. She basically manages a community centre there. And that focus group was held predominantly in Bangla. And she basically translated online during that time for me so that we could have that group and hold it in a language that was native to the women who were taking part in that study, who were answering their questions. Because I wanted them to feel like they didn't have to try and translate. You know, some of them really listen translating from multiple people at a time. So rather than one-on-one interviews, you could perhaps think about the type of methodology that you use. So you could actually gather that information via a focus group where you are just kind of reimbursing for their time, that one person. So obviously reimburse Lily for her time during that, but I was just reimbursing her at one time for getting multiple views. So that's a transcribing, should I say, interviews, even ones that are in English, are really costly. You have to factor that into any funding that you get with your research project. I think maybe a good thing that we've got now is that, I guess, how AI has become much more progressive and we can rely a lot more on things like Microsoft Teams and Zoom have their own transcription function within them. Obviously, they're not 100% reliable, but lots of other things. Where that data is getting stored, who owns that, the app, will the app own that, and a lot of the time, these are very sensitive topics that people are talking about. So, yeah, it is costly, but it's something that has to be.
I agree with you, and I think it's a concern for me because I think it's a barrier to the participation of diverse communities in research when you know, most of your consent forms are in English.
Oh, yeah.
Like that's the research terminology translates well to that language is also an additional challenge and expense. So very often you're thinking about the time you have.
Researchers don't think about at all because you always pay people to take part in these studies. But for them it was a real worry. She had to then explain.
The national services, so the national medical directors and national clinical advisors were standing, it's not a huge resource that they've got to make their sort of policy and their advice to Mr. Streeting and to his colleagues at the moment. I've always felt that policy is never terribly evidence informed. It's groups and APPGs and advocacy groups are so good at doing, you know, because we as researchers think it's enough to present the data, but it's not.
Going forward, absolutely. Right, another question for you, Ed, is what are the limitations of the Embrace data?
Limitations? Oh, well, I think it's wonderful data, but it takes a long time to come out afterwards. But that's almost inevitable with the process of review that it needs to go through. I think it's very rich in what it does, but it looks at top-line mortality, national maternity audit and improved outcomes. That's quite difficult to reconcile with rising maternal mortality. And I think we can say that there has been a secular trend of improvement, change in the time.
How do you reach them? What have you learned from what you've done to share with everyone else?
Yeah, that's a really good question. Have I found them easy to reach? Yes. It's not hard. I don't know why people say it's hard. Drop-in sessions at the community centre to predominantly discuss kind of genetic testing, any of those kind of concerns, but also they kind of trickles on to talking about maternity and all other issues, and it becomes like a little matter. We have this Black Scholars again. I worked with Moore, with Mummy's Day Out, with all will look after them. I think the problem is that change is really slow, and so I feel like I'm already at the kind of end of this journey, but I think for a lot of people, whether that's clinicians, whether it's other researchers, it's funders deciding whether something is funding worthy, they're at the beginning of this journey. So a lot of work is on health inequalities now and equity, and people bandy about, underserved communities and lived experiences, I think, are not all at the same place. And so it's just, I have to remember that it's going to take time, and actually it's just exposure, it's just coming to conferences like this and talking to people and making this work known. Eventually, I'm hoping that drip feeding will have positive impact, but it's not going to happen overnight.
It's socially,
but everywhere.
So you'll be pleased to know this is on YouTube, story everywhere. Okay, I'm going to wrap up this session because we've got a session afterwards. But thank you so much.
Thank you so much, guys. We are continuing with on the sort of agenda. Also, just welcome to all those that are on the live stream. There's quite a few people that have joined the live stream as well, just so you should know. And this will be recorded and put on YouTube, so if you don't want so we're going to have two more speakers in the next session, and then we'll aim to go to lunch just after 1:30. So I'm going to invite Jasmine Lyons to the stage. She is a National Maternity Specialty Advisor, a consultant in obstetrics and gynecology at the hospital. She is also clinical director there. She's a fetal medicine consultant, and I trained with her. Brilliant. Thank you so much.
Thank you so much. What can I say? It's very nostalgic to be here because I'm really here with Karen and Ed. I remember many the coffee room, these late nights on call. And also Bex, Paula is here. She's a midwife. She looked after me when I was on call. So I'm really happy to be here. I'm obstetrician, Karen said, and I work in Hertfordshire. And I also do fetal medicine. I am also a maternity improvement advisor with NHS England. So I'm seconded and I support Trust on the maternity safety support program, who have the poor CQC ratings. So I work with a large group of midwives, and we support them on their improvement journey, culture, leadership, workforce, etc. And also my second role in NHS England is a national specialty advisor for choice and quality. So I'm really privileged to be in this position because it's something I'm very passionate about and really wanted to do some work in this area. So I'm one of 4 specialty advisors who we work with Professor Donald Peebles, who's our National Clinical Director. And as you know, he and Kate Brintworth, our clinical leads. Kate was here this morning, and you'd have heard from her talking about the challenge with NHSC and the merger with Department of Health and Social Care. So it's a challenging time for us, but we're still committed to delivering our 3-year delivery plan and looking at trying to address maternal inequalities. So I'm really pleased to be here. Thank you, Karen. So I think in terms of the themes, education, breaking down barriers, and I thought I'll just talk a bit about what my area is about, choice and personalised care. We know what the reports say, the statistics, and which are appalling, and we're committed to reducing that maternal mortality gap. All the reports that have come out, and we've had 5 times more here, and really pioneering the work in this area and making things better. And all the themes coming out, women not feeling listened to, not being heard, and we really want to improve our services to tailor the care around the individual needs and looking at, so what matters to me, what matters to me, what matters to me. And this is what personalised care is, individualising the care packages that we have and surround our women and our communities. So I thought I'd do from the equity team as well, because I work as part of the maternity and neonatal program team with policy teams. So how can we look at our policies, our guidance to try to support some of the work that's being done nationally. So we know that personalised care obviously looks into individual needs and circumstances, and we know that it looks at deprivation, backgrounds. We heard about ethnicity, not just about ethnicity, but about religion, and really looking at managing these expectations of our service users in terms of what they need, in terms of looking at their care holistically. try to deliver personalised care. This is theme 1, listening to women and families with compassion. And how do we deliver personalised care when our women service users are more complex, they will be and want mental health challenges, and looking at the global picture. So if we think about 3 elements of how we would like to deliver personalised care, thinking about how we prepare our service users, first of all, in languages and formats that they can understand, and we know that's a challenge. We heard about interpretation services, for example, informed decision making. So we're doing some work around looking at decision support tools, around paying service users have said very important to them, so we're doing some work around that, and that will be coming up very soon. So looking at all those, some of the apps, so we heard about 5 times more app, there's a Janum app, there's also other apps. So really thinking about a digital element, how we could support our service users, not just looking at a paper copy, but thinking about the future and AI, and how progress maternity care, thinking about the digital element as well. But to deliver personalised care, we need trained teams. And how do we support our staff to deliver personalised care and equitable care? Challenges, in terms of how they're treated, whether it be about discrimination, the culture. We talk about culture. It's not just about one person. It's about how everybody feels, how we all thrive, whether it be as ethnic minorities. So we really need to think about supporting our workforce. If we don't support our workforce, we can't support our workforce to deliver personalised care and deliver that care to our service users. So there's a lot of work coming out of what we're doing. We've been meeting with regional teams as a personalised care team, and some of the themes coming out is around trauma-informed care, enabling conversations to occur where service users can feel trust in terms of the healthcare professionals, and having these conversations empowered to have these productive conversations around their care. So trauma-informed care with outside guidance is one of the themes coming through. I don't like that terminology, some of you don't like it, but it's an area of a lot of work is being done as well. So we're reading how do we support complex care plans and personalised care plans. And personalised care plans shouldn't just be about a plan, it should be around the experience. It's not just a plan on a page, it's really about that experience of our service users, which is really important. And to deliver personalised care, we need support MNVPs, being representative of the populations that they serve, and the whole culture and system around that. So it's really important that we have engagement and true co-production around delivering personalised care. And we talked about what's the definition of co-production, and we talked about that earlier. So not just a tick box exercise, but whether it be about data, Ed was talking about, so they feel involved from the very beginning to the end to support their pathways, going up to trust boards, hearing their stories, and really trying to be involved in the service and the vision and strategy of all our systems and our trust. So if we recall, in 2021, after COVID, which was again a challenging time for us, we published the Equity and Action Plans, Equity and Equality Action Plans, so all ICBs and systems started to do that, and really co-producing these plans with service users to make sure that they're tailored to the systems, and really to try to improve equity for mothers and babies, and also for staff. And this evaluation has just come through, and they will be published shortly. But really, these plans have shown that everybody thinks that equity is now more of a priority. We're all talking about it, working together collaboratively. So it's definitely a priority for the government, priority for the maternity and neonatal program, a priority for our charities, service users, and all of us here together. And even with engagement, we knew that for the MNVPs, roughly 35% are now from ethnic minority backgrounds in terms of chairs. Still ways to go, but it's much better than where we were before, that even further. In terms of ensuring culturally competent and sensitive care, in terms of what we've talked about in the equity and equality guidance, essentially we've had lots of staff complete this, and 15,000 maternity and neonatal staff, so again that's a lot of progress in this area. We know it's not just about training, interactive lived experience and having these conversations, but it's something, and these modules are important and goes a long way to delivering culturally competent care. And we talked about our workforce earlier. We talked about supporting our workforce to deliver personalised care, and a workforce that's representative of the populations that we serve. And we talked about supporting ethnic minority workforce, and Nafisa spoke earlier about supporting midwives in the South Asian communities, allowing them to thrive. Wendy Oleola and the team have been doing different programs to support ethnic minority midwives in particular. So we've had a Changing and Growing Together program, we've had a wide allyship, ensure our workforce are able to thrive, able to progress, they can meet their needs, they can aspire to have representation at the very highest of levels, and also exchanging, talking about it, we're having white allies, partners who are also supporting us in that journey. So it's not just around ethnic minorities, but how we can addressing racism in the workplace, but also racism as a whole in terms of our service users. So there's some of the work going on for our workforce. So part of it is about reducing barriers. And how do we reduce barriers? We've got our equity guidance we've spoken about. We talked about data earlier, the importance of data. It's been a challenge, but again, we're making strides with that, where our coding for ethnicity has gone up to 96% in 2024, which is really an improvement, but it is a start, and it's the best place we have been to this day. In terms of addressing the quality of personalised care plans and supporting our workforce around the training, we have rolled out personalised care advanced communications course, which was arranged by the Coaching Academy. Again, at least over about 1,000 staff have accessed that training. With these safe spaces, there's some trauma-informed approaches in there, and how we can deliver personalised care conversations. We talked about a teach-back technique, repeating to women, have you understood, what I've said, can you repeat back? Really trying to give professionals these techniques to support these sort of conversations. So we'll be looking at the evaluation of that long term, but it's a start in terms of trying to support healthcare professionals to provide personalised care conversations. We've also got a few interactive tools, some avatars where we can look at antenatal scenarios that will be available online, and they're available already. A few minutes to do, and it gives you feedback as to whether you've managed to deliver personalised care conversations. So these are some of the tools that we're trying to use to support effective communication for our service users. And in terms of guidance, we know there's guidance for what our MNVP should look like. We know that that system is not held up nationally. There are challenges in certain regions, but again, really trying to ensure our service user MNVPs are representing populations. And what about hearing from our service users and getting timely feedback from our service users? And that will help to improve our services nationally. That won't be ready till next year, and we'll also come back. So we've got groups, and again, looking at multi-stakeholders, our researchers, and our service users, policy teams, really want to make sure that that's fit for purpose. So that's a long-term goal in terms of hearing from our service users, that we can measure personalised care, what that looks like. So that's look out for that and watch your space for that. So in terms of community language and translation services, we talked about the importance of that. NHS England conducted a strategic review in 2023-24, and really looking at the framework come out of that in terms of 5 areas of action, looking at access and barriers to services, quality and professional standards, because we know that translation services can vary, looking at digital opportunities, and just as talked about earlier. So really trying to get that right, because we know that it's very variable around the country. So that's an area of focus for us as a national team to support and work with organizations around translation services. And just to end with sort of 2 case examples that we derived from our equity group. In Northeastern Cumbria, and the LMNS, they developed a vulnerable migrants pathway, and really looking at early identification of these women, where they could actually be booked early, looking at extending their antenatal appointments for them, looking at parent education support around their travel cost, really helping them, supporting them in their journey, and having tangible handovers for them in terms of healthcare professionals. So we'll be looking at long-term evaluation for that, but that's one of the good examples we derive from our equity and equality strategy. And in Birmingham and Solihull, they also looked at inequalities dashboard, again looking at data. We talked about that, and they managed to look at their maternity link support workers and developed a group to support ethnic minority women, and really looking at how they foster communication, building trust with healthcare professionals, and looking to deliver excellent care, signposting financial, breastfeeding, etc. So this is just some of the another example that came out of our equity and equality guidance. And what they did notice is that the DNA rates were reduced, and they're able to have maternal vitamin D and breastfeeding rates have increased. To your services, to your needs of your communities, again, they can make a difference, and we're looking at local actions to do that, and ICBs and local trust and systems to work together in partnership to do that. Doing as a national team and working with everyone, we've set up our equity steering group, and lots of you are part of that. The Race and Health Observatory, we've got researchers, you've got our VCSEs, our charities, 5 times more, we've got a motherhood group, we've got lots of stakeholders in this, and really trying to reduce maternal mortality, equity and equality. And the government is committed, and we're at NHS England committed to improving inequalities. We're looking at a national intervention to address racism, and which is crucial because we're in a much better place. And we know racism is not just about maternity, it's a wider issue, and we talked about that in terms of not just when women come to maternity. And we've got the NIH Challenge Fund, again looking to reduce inequalities, and we'll be looking at that. And obviously Nandi talked about the lands from the Race and Health Observatory. So committed to reducing inequalities, and that's some of the work in progress. So please get involved in whatever way you can. The message is collaboration, collaboration, collaboration. And we trust our charities, researchers, colleges, everyone together, because if we don't do this, we'll not make a difference. Thank you, everybody, and thank you for your time.
Thank you so much, Jasmine. We are just moving on to the next set of speakers. That's the Black Maternity Mat. So let's just make sure I have that up. Ed, you might have to help me. Yay! So, these are two very, very special people. So hands up anybody who knows this team. There's just a few of you. You are in for a treat. I was invited really kindly by Anne to go up and to basically speak at a graduation ceremony that they do in Black Maternity Matters. This training is excellent, it's exceptional, it involves everybody in the system, not just the ones of us that are interested. Directors, consultants are involved, it's not just the midwives doing cultural competency training, and I brought them here to really open your eyes to what we could achieve if we took on what they did. But
thank you so much. It's fantastic to be here, and we're really enjoying the speakers that you've had. Thank you so much, Karen, for inviting us at previous talks and thinking about how a lot of that has influenced what we're doing, 5 times more, and we're working with the Race and Health Observatory as well. We really stand on the shoulders of people that have been pioneering this work for a long time. My name's Anne Remmers, and this is my colleague Nushan, and we work for Health Innovation Network West of England. I don't know if you've heard of Health Innovation Networks, but they used to be called Academic Health Science Networks, but don't worry about that because, you know, that's just another acronym. You don't need to worry. To improve safety for mothers and babies, and in general in healthcare as well. But the programme that we work on is the Maternal and Neonatal Safety Programme, and now Black Maternity Matters. And we always start with this quote because it's very, very dear to our heart. It was said by one of our very great partners, Sona Patton from Black Mothers Matter, who often does we do a three act rather than a double act. Sona couldn't hold this in our hearts and in our minds. No matter what I do to prepare, my safety is in the hands of the healthcare professionals I meet on my journey, and Sonna speaks very powerfully about this, that is really worth listening to as well. Oh, you've done it already. Thank you so much. I don't really need to go over. I think we know about the disparities, but it really came to the foreground, I think, after Black Lives Matters, and then the 5 times more work that they did around maternal mortality, highlighting maternal mortality and maternal morbidity as to why we needed to raise this. Really, that's what we were working in, patient safety, and we've known all these statistics for so long, and what were we actually doing about it? How are we changing those conversations and the care that women and I think what we really wanted to do as well was really kind of highlight that this was the programme was an anti-racist programme. People have been kind of cultural competency, cultural diversity courses, but we really wanted to focus on that we were targeting the racism, and that was what was making the difference. But the other thing that Sonna said is, and the Black Mothers Matter community, which you'll see a bit of going to show, is if you're going to do something, make it something that changes, that brings about change. So we wanted to develop a course that really took people on a journey. It's 6 months, you get time to reflect, and we also support people with quality improvement. So they go back into their organisations, they immediately start thinking about what can I do and seeing things, and that's what we wanted to make an impact on. So this is our celebration. We do a celebration, and we're really lucky. We don't have the expertise, and I think other speakers have said it's about finding the people, finding the communities that really are experts. So we didn't have the anti-racist education. So we got to know Katie and Aisha from BCOCO and Representation Matters. They are absolutely amazing at Deliver Matter, who's our other partner as well. So this is the vision, I think, I've made very clear, but we take the onus away from Black mothers and their babies for this. We wanted to take some responsibility as the people that are providing care, to educate staff to how the impact of racism and how that can perpetuate harm, so that we could really try to improve outcomes and improving a driver for us. And the courage, I think it took a lot of courage to keep saying, look, this is important, this is a patient safety issue. We need people, we've got hours or a day, we need to take them on a journey so they have time to reflect in between each face-to-face session, that they have books to read, education, resources and real experts, because it's an eye-opening programme. I've done the programme myself. And it's hard to explain, you know, what you actually learn. And you really also, people need support as well. So we really wanted to do that. And the courage also comes from people and saying, I need to be on this programme, I really want to be there. And also the organisations that supported their staff and actually really kind of put their faith in us, because when we went along to talk to directors of midwifery, said, look, instead of that day, that couple of hours, would you just bring, you know, let your staff come on a 6 month, you know, that we really had to convince them, but they had the courage to put faith in us. And this is Sonna, and this is another of her quotes, which I think it's so powerful that, you know, people think, well, to somebody not getting the care, not coming forward for the care, not receiving the information that they need. It doesn't necessarily need to be a big thing. It's lots of little things.
It's at the heart of what we do. We are greater than the sum of our parts, and so we have worked with and learnt from, as Anne said, kind of the leaders, the thought leaders and the people leading the action in this area before us. And these are some of the people that we have kind of worked with and continue to work with to deliver what we've been able to deliver. Oh, that leads in well. So greater than the sum of its parts. So as Anne said, we needed to design and deliver the anti-racism education part with people who have been doing this and who are professionals in the area. So we are really honoured to have Aisha and Katie lead that, and they've now trained up, now kind of refined and developed the model. They're now kind of adding to our pool of educators to do that with us. We work with our local LMNSs and the trusts. We co-design it. So when we trust in the needs of the trust, Black Mothers Matter, what a gift that they were working in the area with us. They have become our bestest friends, but they are an incredible organisation. If you don't know them, I'm sure you all do, check them out. And then ourselves, we do all of the boring bit. No, we don't. We do all the kind of coordination 6 months, and they're full days and they are full on. And we have seen people come out of there just with their minds completely blown, with their eyes open, which is what we want to do. And then people come together in between. That you know, clinical time is precious, but we bring them back together in book clubs, so everyone is given set reading text at the beginning of the course, and QI support and coaching, and that's all virtual, and there's lots of different opportunities for people to get involved in that, and that really helps them to identify what they want to work on, work it up, measure it, share that. We all know that quality improvement, doing it kind of, you know, for a clinical intervention is one thing, but doing it in the field of anti-racism is a whole other beast. We properly immerse people into anti-racism theory and practice, and it's through an anti-blackness lens. It's frank, it's confronting, and it really puts the onus on the people in the room and harm in the work they do. So we have trained nearly 400 people, and as we said, we've captured them. So we bring them back together, we bring specialist speakers, we have Keep Talking, we have WhatsApp groups. So we're trying to build a really vibrant community. Really importantly, we obviously the training's open to anyone in working in perinatal services, and that includes people with lived experience of racialisation. So people who are racialised as black and brown or from the global majority will come on the cohort. Different experience for them than it is for people racialised as white. So we've built in a really supportive wraparound kind of therapeutic offer, I guess, for people who have debriefing sessions with a race and trauma-informed counsellor, psychologist, if people would like to access that. We have brave spaces, so this is bringing together people who are racialised as black, holistic. They have they do movement, they do debrief, they do, it's just beautiful, share food, really, really welcomed spaces. And then we also have started to build in race trauma-informed education into the programme as well. And we're also now looking at spaces for people who aren't racialised as black and brown or from the global majority, who are really grappling with whiteness and the kind of learning. So just more space for them away from people who are racialised as black and brown, because we you know, let's give people a break and let with an expert. So this is a short video, and these are lots of our friends in here, and they can say and tell you about the programme way better than we can right now. So we'll just works. No.
Okay. Black Maternity Matters is inspired by the vision that one day women racialised as black will know. The statistics are grim. When I had my youngest child, I learned that as a black woman given birth in the UK, I was 5 times more likely to die during childbirth or up to 6 weeks after. The statistics continue to tell us that black babies are more than twice as likely to be born. We've developed an innovative 6-month anti-racism education and training programme designed specifically for staff working in maternity and neonatal services.
This is very innovative and quite revolutionary. Most people are used to getting a 30-minute e-learning module on a journey with us. It is a vast difference in approach, and it's a real immersive practice that we're providing people to step into.
The journey participants to get introspective,
to think about who they are, their belief systems, values, principles, their understanding of race and racism. Okay, so we start with building some foundations for them, okay, doing a bit of myth busting, especially through the lens of their profession.
Black Maternity Matters is making a difference, transformation of individuals and teams and organisations to really embrace and embed anti-racist practice and theory.
Everybody that comes on Black Maternity Matters programme, I'm doing it myself at the moment, I'm currently one of the participants, and it is a total transformation. You are learning so much and you're unlearning a lot as well.
Unless we're actively anti-racist, we are passively allowing racism. Definitely everyone in the NHS needs to have the opportunity to really examine what racism is, where it's happening and what their part in it is. Are you passively allowing it to happen, and how do you stop that? Because most of us are passively allowing it to happen, and I never thought I would say that.
What's been really beautiful about this work, and that's a beautiful opportunity, because we have the people in the system who have the power to make institutional change. That's transformational, because not only are we talking about what we do on the ground, we talk about policy, systems and guidance, and that's when we can really begin to see the ripple effects of our work. That's massive.
Because the power that they have, and when they get it, they really get it. So it is very, very exciting. A little bit daunting because it feels as though it's getting very big, and I think that's one of the reasons that we wanted to take our time, the integrity of the programme, and not to lose that.
Our ambition and goal for Black Maternity Matters is that it's in every NHS trust across the UK, and that it really is embedded. The compassion and kindness and collaboration it brings is just part of how we work in the NHS.
We started our community groups bringing together Black women in Bristol, and when we started, when people would come to us and share their nervousness about leaning into NHS services, there wasn't much we could say. But now we're on phase 4 of Black Maternity Matters. I'm proud to say, with a bit more confidence, I can say actually there are lots of people that are working in the setting and that are on this journey and are committing to doing better by you.
Thank you. I'm conscious of time. Try and go through some of these.
The impact bit. Is
Yes.
that okay? Have we got a bit of time? Yeah. Okay. This one, start here.
Yeah. So. Just to say that when we started developing the programme was 4 years ago, and we've evaluated each stage. So we've evaluated the pilot, and then each year we've evaluated, and these are some of the comments that have come out of the evaluation. We're just publishing our second evaluation report, and we'll be publishing one on the senior leaders that have been through as well. That's the geographical area that we cover in the west of England. So we've got Bristol. Bristol's been doing the programme for the longest. Those are some of our cohorts. And this is the impact. This is some of the examples of the impact that has happened.
So these are some of the quality improvement projects that people are working on. This is kind of, there are so many, so this is just kind of an overview. But what we do is kind of, when we get them to test it through the quality improvement programme, the idea is then that spreads across the west of England region. And then, as we said, we also hold kind of specialist interest QI coaching workshops and bring everybody together. Here are some of the other things that have come out of Black Maternity Matters. So you can see these slides after. We'll give you time to have a look at them in your own time. This is a really exciting project. So this is an immersive case study that was done by Asha as one of the Gloucestershire Black Maternity Matters cohorts. So we can share these resources with you as well. So as Anne said, we've been evaluating it, so we know that the training works, we know that there are shifts in behaviour, and we know there's shifts in knowledge. The next bit we're doing is looking at impact on clinical outcomes. So we're working to set up a clinical reference group so that we can look at kind of the impact not only on the clinical outcomes but on the experience of women, families and babies. And this is something we're really interested in. It comes out in every single evaluation that kind of people massively overestimate their competence in anti-racist practice and theory. So we ask them at the end of the programme to go back and look at what they know now, having spent 6 months with us, and they all kind of massively change their kind of baseline. But this is really important because it really helps with engaging those people who are dragging their feet a bit, or the ones that will tell you, we don't have a racism problem here, I treat everybody the same. We can actually demonstrate that all of those 400 people will tell you this, so that's really helpful. And I'll just hand over to Anne to finish.
Yeah, I think one of the things that we started off with perinatal cohorts, and then we brought more sort of senior managers as leaders cohorts. We've had chief executives, chief nursing officers, people in leadership positions across the Southwest. And what is amazing is when you get somebody in that powerful position who gets it, and they go back to, and we've had a chief executive of one of our trusts who's just, she said it's transformed her life, and she wants everybody in her organisation. She said, right, I've got 12,000 people, can you just train them all? And we're like, no, not right away. But we'll do a pilot and we'll try it, and so it's maternity, and also for the staff as well, for the experience that staff have working in a large organisation when they're racialised as black or brown. So that's something that's very, very exciting. These are what we want to do. We're developing an anti-racist perinatal clinical bundle, which we've got some wonderful people that we've got some more ideas about more people we want to pull together on that just from today. But continuing the collaborative, continuing the community of practice, and continuing to learn. That's what we want to do.
Touch with us, yeah.
Yeah.
Sorry, we went over.
That's okay, it's definitely worth it. Do you know what? It's off a little bit, it helps your gut to heal. So, we're going to take some questions. I had to get that in, didn't I? I could not resist it. So thank you. I hope that's been really insightful to all of you. It's just about us getting to know the work. So a few questions. So use your Slido to put the questions in. Are there any plans to make the cultural sensitivity training mandatory on the national scale?
It would be lovely if we could do that, isn't it? But it's probably something we need to think about. I guess like more basic training. It's not incorporating it, stressing the importance of it, and encouraging that uptake. So it's something definitely a challenge to us, I think.
But, and so I'm going to push you a bit more on that, gentlemen, because that was a really political answer. So what do you think that's something that we will get it right? I think they showcase quite clearly that it's about a journey of transformation, which benefits all of us. And do you think that's something that would be considered nationally?
Yeah, I think so, and that's why I'm all for training. But I think we do have to start somewhere, a bit more creative as well. How we do our training, bringing in not just a module where you sit and tick a box, or people are on their teams doing training. So I think it's really embedding cultural competency training, but also thinking about how we bring in user experiences into that. I think that so I think we need to think globally a bit more.
Yes.
Pushing for it, yes, everyone should be.
I'm sorry if we've been using acronyms.
Finally, so it's maternity and neonatal voices partnership. So that's what it stands for. So initially, maternity and partnership. Yes. So it used to be like some service users. We have many lived experiences coming to share their journeys. So when we have babies or who have gone through the system, and we normally come together from a group. There's lots of guidance around how that should be delivered, because the idea is to have our voices of our service users involved in maternity transformation, our policies, our guidelines, our pathways, and we bring neonatal into part of it, because we tend to exclude neonates a lot sometimes, and women and families. So, and we're trying to strengthen that nationally.
Fantastic. And then any questions from the audience? You put your hands up, or who's getting down there?
Just to that power that we found in finding a group of women You know, the people, well, I think sometimes, and I've worked in the NHS a really long time, I think we know more than we do, and we need to learn from others.
Just got a question there.
I really enjoyed all your presentations very much. Everything that's gone on today is absolutely inspirational. Once you finish with maternity, are you going to expand your training to other groups? And also, does it cost to do your course? I don't know if you said that in your presentation, but I missed it. If you did.
Sorry, you are my colleague. So we have adapted Black Maternity Matters for an entire acute trust. So we're doing a pilot there to see what it looks like when we take it outside of the cohort, and that's really impactful. We're just evaluating that now, and then we're doing an NHS Southwest cohort. So that's kind of outside direct kind of clinical provision. The cost. So it does cost because we pay our trainers the exact amount of money that their kind of expertise demands. So there are many ways in which you can do it. So people can cohort, or you can it's a conversation outside of here. There is a cost. Talk to me later or email me, and we will. I'll show you the different models. Yeah, of course.
And from the national team, we've also been engaging with you, and we've been quite impressed with with the content of your program, and even as a maternity improvement advisor, when we go into the trust and we can see some of the trusts have engaged in this work. And I think what I would say from a national perspective, whatever program we do want to roll out in terms of actually key to support ongoing work that's happening in organizations such as yours or any other work that trusts have on anti-racism discrimination, we really want to support that and promote that, and not to cut the gap between things at the local trust and the systems level to populations and for staff.
Thank you. And then one last question, I think.
Sorry, I've got it.
Yeah, there might be one more after that.
I got it here. So
okay.
I just wanted to know, because you talked about you've done part of an evaluation and you've seen different change in knowledge. Can we access that? Is that publishable?
On our website,
okay,
you get access to the
Yeah, I think what we're basically pushing you to is that needs to be published in the scientific literature, but Michelle or myself or Ed, we will support that after. We're trying to get people to think about publishing it now. It's really important because it's gaining that evidence base, it's getting your work out there, and it's great, as you can see, they've been doing this work, but evaluating it. They didn't jump on that. Yes, I'm going to do a whole activity in acute trust training for 12,000 people. They said, no, we need to evaluate it. And unfortunately, in the EDI era, lots and lots of companies, and it just we didn't have that real richness of evaluation which you've used. So there's one more question, I think, and then we will go to lunch. And then we'll aim to get back from lunch myself and our team, talk about the work we've done, and we will whiz through that. So you go ahead.
I was just going to say, I think honestly what you guys are doing is fantastic, and a little bit as you started to comment, realize perhaps how influenced by race their care is, or they think, I don't have a problem, I don't see colour, etc. I wanted to ask how much specifically, because great things, either for care providers that have already done years of education, and ultimately we have still a very colonial, imperialist education system. So how much are we going to focus on the root cause, which is decolonising our education system from the root, so that when people are leaving medical school, they already are going to be a little bit more adapted.
I think I might take that one actually. Obviously, head of school for training, this is why you're actually here at this talk, and to share information, but it's to gather information about how we train differently and how we do basically everything from the curriculum all the way to simulation, and that's what we're going to go into after lunch. So we'll hold that. So we're back at 2:20. Don't forget to look at your Slido. There's a little, a bit of a poll ongoing about what you would do to change inequity.
Places to get lunch. So for fast lunch, I suggest everyone at the back goes that way, and everyone at the front comes out here, turns right, and this way. And there are posters over here.
Yeah, perfect. Thanks. Yes.
connect our laptop to here?
Sorry, where's
to the screen.
Yeah,
there's another person who
Oh,
just
sorry,
so
sorry.
where's
Where's the thing you sent?
Oh, I have just sent it to your
Sorry,
email.
you sent it to my email just now.
Yeah, it's there you go. Yeah. This one, if you can explain from this. And then you have to write your email. Sorry. Yeah, that's one top one, isn't it?
Here.
280-77710. I'll remember.
All right. Okay.
280.
Thomas says where Shri and Anita work. So really, just remember this if you can. These are the three pillars. Can somebody just grab everybody either to come and talk so that we can all close the door maybe, and we'll do that. So this is something that you're going to be looking at a bit later for your own organisation or your system. So take a quick photo if you can, because we're going to be doing a really short workshop at the end, just when you're about to fall asleep, to keep you awake. You through some things that we went through. First pillar was really thinking about case studies and stories. If I go back one, it's all about patient stories. We've talked about that in the beginning, and that's really just to lay the foundation and the scene, and that's ideally always what you should do if you're doing any piece of work. What are they saying? What are the barriers? What's the communication? And what are the stereotypes that affect you? What do they hear? And how do their previous experiences impact trust? The next pillar, if I take you back again, is about clinical interface and staff. And today we've also talked a bit about communication, so that you use within your organisation, just to remind you, just to trigger you. It's just not the same with every person. Are you safety netting? Are we asking them what they need? Are we addressing their fears and concerns and opening up that conversation? Are we infantilising them, saying, oh, you don't need to know that information, it's too complex for you? And then the last thing is thinking about health equity impact assessment framework, and we'll talk about that a bit later with Shri. And I love the phrase that if you do it for black women, you affect all women. And that's the core theme of doing work around health equity. If you pick the group that is most disadvantaged and you create a better care or a system for that group, it will affect everybody and it will benefit the whole system. And it's really, really important to realise that. So evolution of PPH care, lots of stuff from surgical to pharmaceutical to resuscitation protocols, but we're still not getting it right. We see in units across the UK up to major hemorrhage after having a baby. And that's just not acceptable with the degree of technology and advances that we have. So when I said get with doing patient stories, we went back to what was our unit data? We couldn't just presume that we were okay. It didn't really feel, it did feel actually at the time, it didn't feel at the time when they decided to do this project that we had a high hemorrhage rate, although everybody always thinks that Queen Charlotte's does. But when we then drilled down into the data and had a look, disparity between Asian and black women in a comparison to white, 2% higher, really wasn't acceptable. Overall, PPH rates actually weren't so bad comparatively to the rest of the UK, but still, there shouldn't be unequal care. So we drilled down this a little bit further, and I'd encourage you at the coffee break just to go and look at, there's a couple of posters that are up, and we'll send the remaining really good poster that was looking at how women deliver on a care set that was also in Outwards, is that black women were having higher unassisted deliveries, but yet their PPH rate was higher. So we can't put it down to trauma from instrumental deliveries or cesareans. must be something in the care, the way we did our blood volume for a while, although, as you can see in the study, they talked about the racial and ethnic differences were still different when you find the blood loss. We also looked at a little bit of patient factors. I thought, where are we going to act on this system? Should we look at anemia levels? I thought, well, that will take, you know, months to try and get that. We looked at system factors, and I really love my anaesthetic colleagues. I love where I work. I love it because it's very multidisciplinary. Always be curious. Don't presume that we know it all. We've said it here already today, but it's really digging down. So just because the MRHA, which is the medical sort of services authority, it's devices, sorry, says it's okay, is it really okay? Are we doing our APGARs correctly? We know we've got that neonatal work that says we're not. SATS monitoring, COVID told us perhaps we're not. We started to think about pallor or cyanosis. These things we're not picking up as we should do. Are our SATS monitors overestimate? But the anaesthetic discussions that I had that said to me, Karen, we're always called into the room late. They're there at the time. They can do the intervention with the drug protocols needed to reduce the bleeding. But if it's somebody in the room, you've got the midwife on her own in that room. Sometimes the room is dark because that's what it's wanted. They're not able to be late, and so they're called in late. So I think we started to think, could we do something different? It's a real disparity. It's not just about PPH, use of blood. It's a psychological morbidity as well, and it's got significant improvement. So we decided to try and streamline it a little bit, and our action for Toolkit was basically saying we want to make it equitable by earlier recognition of the deterioration of women with darker skin, to address the variations in care and achieve normal care and equity as well. So we had a few change ideas. Let the midwives do, and it's really understanding, actually, as a healthcare professional, once you've been in the system for 5 years at least, you don't really need to write anything down or tick it. You kind of know it. You know if a woman's high risk or low risk or medium risk, or what her risk factors are. So, and the midwives just don't have enough time. We really bombarded them with about 50 different things to fill out in labour and every hour. I still don't know how midwives do it. It's just every 15 minutes they're writing down all the observations. It's just like, wow. And so that work was done before we started this by our unit, who's always really thinking about how to improve care anyway. And so we thought anything in there that's telling you to assess somebody differently on the colour of their skin. And then we looked a bit in the floor in assessment tools. Again, it's difficult to detect sweating, flushing, pallor, so clamminess in darker skin tones. If somebody's hot and flushed and they are going through like a septic shower, you may see it in somebody with lighter skin. You wouldn't see that in darker skin. When people are starting to bleed, you'll see it in pale skin before. You may see it on their observations, and that's really important to remember. It's really significant. And what then happens, it runs away with you because you're not just losing blood, you are losing clotting factors. So therefore, the overall blood loss is likely to be higher. And so what we decided to do is and there's different variations when you're looking at PPH. Traditionally, people look at 1.5 litres. We thought we would look at 1 litre because we would be, our MDT approach was to really talk to everybody. Anaesthetists, for me, were really the great sort of innovators in this work because they were bolder in the use of some of the medicines because they were used to using them as a norm in vaginal delivery. But we talked to all these different groups of people, and we had some co-production workshops as well, which some of you may have attended. So this is the algorithm. Great thanks to Natasha, who's been running around with the mic, and Georgina, who helped put this all together and create a lovely algorithm for us. And this algorithm, the reason why it's different is because what you don't realise is when people come to labour ward, I'm going to be very and they are going to get something to help stop, prevent excessive bleeding, we call it third stage management. So when the doctor comes along, what we traditionally would just say is that, okay, this person's going to have, and that's probably all we said. And that was it, and you kind of leave the room. So we didn't define or break it down according to how much risk that woman has. And we've got probably about 10 different drugs that we can give. So therefore, you can have a vaginal delivery with minimal no risk factors and get the same third stage management as somebody with fibroids, anemia, sepsis, large baby. So that's where you can sometimes get disparity in care. So we wanted to move people to thinking about PPH prevention algorithm, which is when you're really risk assessing, not just because you consciously know, but looking at an algorithm to and give you basically the power to give additional drugs. And one of the ones that we really liked was tranexamic acid. I'll take you through that. So some of you may know it, you may have been given it for heads. but it's also something that we know has been used in trauma work, and also recently in guidance says that we can use it for sort of in obstetrics. A women's study in 2017 said it reduced using it, and the implications for obstetrics is that it was recommended in guidelines from WHO and also the RCOG. But a little caveat there, it should be used alongside uterotonics. And where we saw this work is that it worked if we used it with the uterotonics, but what sometimes happens, people will concentrate on the TXA and not using the uterotonics, and therefore the blood loss was still significant. We saw that in our sister unit in the Royal London, who also took on the protocol and used it in their unit. And there's lots of barriers because, you know, the other problem is gendered, it's not just gendered, where pregnant women often don't get access to care because they're pregnant, because nobody wants to do the study because they're pregnant. So with TXA, people were worried, is it going to affect the baby if we're giving it a little bit early, dilated, because that was the prevention strategy. And then I went to the neonatologist, and they said they would give TXA to a baby if it were to be born. I'm not concerned about thrombotic effects. The study didn't, people also said I have other strategies that work. So I did a quick comparison of the women's trial, which is the first one I mentioned to you, and the second one came out. The second one came out, and it actually doesn't make that much difference. But what people forgot is that it said it doesn't make that much difference in anemia. So it still makes a 30% difference for everybody else. But if you take out the women that are, but they think it may make more of a difference if you give it early. So let's just drill down, hold that space, into what actually TXA does. People are thinking that it's just a hemoglobin, but it's about your clotting factors as well. So TXA is also used to create, not TXA, sorry, your iron is also, it's not necessarily working in the women that are anemic. So there's a study, some work that will be done by GSTT as part of this project to try and stabilise the anemia in women beforehand project. And there's some other teams that did that as part of the NHS Race Observatory. So essentially, it's really important to recognise, first of all, iron deficiency anemia must be treated because it can impact your clotting factors, but also that TXA is really important in all women. And WHO, as I've said, it recommends it, RCOG and NICE. Blood shortage, we said that everybody should be given TXA. We also recognise that people have been using blood as a crux. They use it to think, actually, there's blood bank there, you know, so you're not really preventing it. So in your units, you should almost think, what would you do if there was nothing available in terms of no blood available? And we had a wonderful unit, not a unit, a gentleman that was doing a study. He was like, yeah, so how do you manage PPH? It must be organs. Like, no, we're not that worried about hemorrhage. We're more worried about fibroids. And I said, oh, really? He said, essentially, they gave everybody iron, so nobody minimised the anemia dramatically. Everybody had misoprostol, TXA, and Sintimetron at the time of delivery. So generally, their blood loss was not such an issue because they knew they didn't have their blood bank. So when we started looking at our quality data after we implemented it, people said, oh, it makes perfect sense. Why did we just say third stage management? We should have a system to prevent rather than react. They were more confident in using TXA. The midwives, as they understood, and the anaesthetists were also more proactive at caesarean section to give it with knife to skin. They were happy with using Sintimetron. We had a protocol around making sure you give the antiemetic about an hour before when they're fully dilated, so women don't worry. It's, you know, vomiting is far less of a... so I know a lot of people were worried about Sintimetron, but we got rid of that real side effect with the antiemetics. And again, it's to really mentioning that it should not be prescribed. This is the control site, and really the numbers are different for both, but this just shows the variation in, you know, PPH. There's almost like no order to it. With the white one is the green line that runs in the middle, and the black one is the one that runs above with the dark black line. So this is our one. So if you think about the one on the axes have changed a little bit because of that spike. So the bit on the left is a bit like the first graph I just showed you. But what I want you to see is that after we implemented it, apart from the mixed race population where actually the hemorrhage rate became even lower, everything is starting to go into one thread. So our rates were becoming a lot more equal with the implementation of this protocol. It can make PPH equitable. And that's some of the data there. So we really feel that education is really key to this. It's also, it wasn't just about the protocol. And I discussed with senior midwives, people at handover, anaesthetists. I went to the consultant obstetrician meeting. I went to the consultant anaesthetic meeting. And if you look at the major causes of women's death, we were talking also about the you may miss the flush skin. In bleeding, you may miss the pallor. And if you look at that, they make up a significant percentage of those women that die. So even focus and target this group alone, we will recognise what we can't see, which will cause us to act quicker. And I believe that has changed some of the practice in our own labour ward. So we're really trying to embed the whole story about don't miss the signs. And this is a poster which ChatGPT helped me to create, and I'm hopefully getting a bit better. But it's essentially just saying don't miss the signs, ace it, get that treatment right. Think about the pale eyes, the pale lips, the pale nail beds, flushing or pale skin from blood loss may not be noticeable. And be transparent about what happens on your unit. Think about PPH deep dives. And always be really curious. Don't think we've always made it. Because I bet you if we just take our first, so this is something that just needs continually to be embedded and for us to look. Thank you. Okay, and so we're pleased to welcome Shri, who's going to come up and tell you about the work. Where is it? Where's it gone? Okay, sorry. And
hello everyone. It's been really an honor to be talking to you in front of. In fact, we are not presenting. This is a work in progress. One of the reasons we are presenting is also to seek your input because it is something that we are developing from the scratch. So I think we all know that, you know, for any hospital, any management starts from a guideline. So we need to have that as a baseline, and then comes audit and quality makes an impact on the care. It's all. And we know that it does. It's not the case. And most of the time, you know, there is always, you know, some of the guidelines recently, they ask for health equity assessment impact, a few tick boxes, and then they say, yeah, it has been assessed. So we thought, you know, it is absolutely important to include this in embracing inclusion in clear steps. Of course, you know, that is not the only thing that is going to achieve, but at least, you know, we should start doing the basic things correctly. But sadly, even with all the developments that's happening, we know that lack explicit attention to equity principles. That was Anang Shah, the clinical, quite a significant literature search on it. When we met for the first time, you know, we had formed a task group. You know, there were different. One group was working on simulation training and change implementation, and our group was given a task of how do we assess the guidelines for the health equity. So that was the task group. So we just described until now, but we know that there is still work to do. So we thought, okay, we will have to go through the process of a prospective qualitative study. So to start with, we started off with the focus group discussion, which is, you know, volunteers who feel passionate about this. So it was a very open and voluntary inclusion-exclusion criteria for people to be involved in that. And people of various backgrounds, midwives, obstetricians, anesthetists, medical students, so all level of experience. And, you know, obviously looking at this room, you know, we all come from very diverse background. So the first, you know, we have a guideline and would say this is addressing health equity. So I think, you know, it was a brainstorming session essentially. And then people came up with a few questions or data. And these were the questions people said. These are the important questions to answer if we say this guideline has taken. So Anang Shah, then what she did was, you know, she took these questions and she looked at the themes, because, you know, it is hard because what we developed, we also want it to be something simple and easily adaptable for everyone. So she just put them into 6 themes. As you can see, these are the 3 main themes. This will be repeated a few times over. And then, you know, we just went to see, we don't want to reinvent that literature has anything been done like this. So, but, you know, there are health equity assessment tool, and it tells us what it is and how to use it. So it's all Anangsha's work, and I told her she should speak, and for some reason she has asked me to speak. I don't want to take any credit. I'm only speaking on her behalf. So from these evidences that is in the literature, you can narrow down. These are the 13 criterias that has got a significant impact on the health outcome. So we are not talking about the protected characteristics here, but the inequities which could have an impact on the health outcome came up. So what we thought was first, obviously PPH was a theme that we had taken. So initially we thought we will go by the local guidelines, and then we realized, we are doing locally. So we thought, okay, let's go for a bigger one. And so we took all the national and international guidelines, and we thought, they might do some better justice than what we are doing locally. So applied all the 13 health equity principles on a very gross basis. And you can see the bottom one, the box, how well we are scoring. We could have total out of 26 maximum score. Something that is, at least frankly, even our national and international guidelines to not go anywhere near health equity. Everybody is shy of it. So this is the basic start. But obviously, you can see, and Anangsha had done a beautiful statistics analysis. Obviously, even without statistical analysis, we can say how bad these guidelines currently are. So this, if you take from the literature, that is, it's very simple, and you can quickly screen them, seeing whether they, it is important if a local population has a significant number of migrants, then you will expect them at least the guidelines to score high on that, because sometimes it's impossible to score high on all 13, but at least depending on your local demographic, you should be scoring high on that. Obviously, this is, we think, this is something easy. And, it is, if you want to quickly scan a guideline through, going forward, we can apply this to all guidelines. Sometimes, when there's a toolkit like this, people writing guidelines will start writing to match that. So hopefully, it will create change in that way. But of course, there are quite a lot of limitations here, because we are only looking at the headlines here. We are not looking into the details of each of these criteria with that toolkit. So do you want to describe this one, Anangsha? Because you...
so we're doing, so I'm doing a systematic review on this, and that's how we are analyzing just the Green Top guidelines. But then when I met Dr. Sri, I heard about this project, and then we focused in the other Green Top guidelines as well, and it is lacking significantly. So the limitations of this particular study was, one, it was just limited to PPH guideline. The different other guidelines will have their own perspective, and maybe we could add some other domains on top of the 13 domains. It's not just the 13 domains. The second one was, there are certain terms that are objective, like vulnerability. Like, what do you mean by vulnerability? Disability. What do you mean by disability? Is it neurodiversity we are talking about, or is it migrancy that we are talking about, or migrancy can... then there was definitely a lot of lack of generalizability of the recommendations as well. So there are various headings under generalizability. And based on this particular this particular toolkit, which has got 13 domains, as I said, it was not possible to probably fit every guideline, like the malaria or the SGA management guideline, into this particular toolkit. But as Dr. Sri said, that overall you can get an assessment quite quick. We did not repeat the work of HEAT or PROGRESS. Those were, like, PROGRESS was a framework to see systematic reviews. HEAT was a toolkit which was quite difficult to implement, screening the guidelines. That's why it was not being lacking health equity. This was much more user-friendly, much more I'm sorry. This was much more user-friendly, but again, the limitations meant that it was just restricted to 13 domains. We can obviously see that how it can be catered very differently to the different other guidelines, but that comes to mostly implementation. As I mentioned, subjectivity in certain implementation. There was no PPI input particularly in this creation of the toolkit, so it was mostly midwife opinions, or so we generally did not have a women's voice input, so that's something which could be incorporated in the second phase of the study as well. And which was we haven't yet looked is the representation in the supporting evidence, which is the systematic review that I'm doing is looking into as well, that the evidence that's supporting the recommendation in the Green Top guidelines has those, like the women's trial, for example, or various other trials, in those particular papers have they certain limitations which are already in the process of being addressed through the review as well.
So, of course, because our prime focus is, at least race and ethnicity, but as you can see, there's quite a detailed level of it. Let's take one domain. One domain, and so we looked at the race, ethnicity, and culture. So, we took the 6 themes that we developed and we scored them again. Again, you can see that it's very, very poorly scoring. We gave -1 for representation and diversity in guideline development because, we have been talking about, other people at the table who make decisions. It was not possible to know because somebody's name might look like one ethnicity, but you don't know. You are not going to go Google and look at that. And so that is something that we are going to discuss. So I think, essentially with the initial toolkit we have developed from the focus groups and the one that we have got from the literature, we feel, and I think, that is just an initial observation, but going forward, when the guidelines are written, they should be written in a way that could answer the criteria that we are looking for assessing the health equity. So I think one of the interesting thing that we want maybe now or later during the focus group discussion is, how important, for us, if we have to look at the guidelines and say, there are good representation, how are we going to make that assessment? Is it important? Which means, do I want to declare my protected characteristic every time when I write a guideline? Because, so how comfortable would we feel? And is it that important? Is there another way? In which case we can take this out of the guidelines, our idea of how we make sure that the authors and reviewers represent the population for which the guidelines are meant. So, yeah, I think, we feel and we are quite excited, especially with the academic input. We are hoping that we could develop it into a more robust tool, and hopefully very soon we'll be able to share with you.
Thank you so much. So just hold those thoughts in your mind, because one of you will come to, sorry, we're going to split into 2 groups, being a group with them talking about guidelines. So I'm going to just invite Anita to come out now, if that's okay.
So guys, it's Friday, and so it's great working with Ed, Karen, Sri, and all of you that we work with. And why am I talking about simulation in training? So my first question is, who has been involved in simulation? Who's had to do it, simulation, yes? And then who delivers simulation in education? Okay, yes, okay. So education belongs to everyone. Simulation is a tool. And we know for every single report why it matters with the human factors. It is about the drugs, and it is about what to do when, where. We know communication, leadership and teamwork is where it can not work. Okay, so when we are educators and teaching, and we are having an opportunity to say this, almost 10 years ago now, we got some money from NHSE in St Thomas's, and we did 35 courses, 350 people on medical emergencies and pregnant. Anybody? Yeah, yeah. Okay, those are the days. Yes. But what we did with that study and that work with those 350 delegates, and you did sign for this, we did an analysis of teamwork. We were actually recording every single one of it. We were not per se doing something. We were looking at your behaviours to something. And what was really, really interesting, again, my slides have gone as well, is that scenarios where the clinical performance was really good was almost to a simulation scenario. So that, in honest world, in real world, when you walk onto labour ward and walk into a room, the women have sussed us out. Yes? Okay, so you've got to think about that beginning really matters. And what we found when we looked at medical emergencies, so this is a few years back, is that actually what was really interesting was that it was better when there was shared leadership, you're all working with the same thing, and midwives and doctors and other health professionals getting the task and information gathering. So remember this as we're thinking about simulation to get equity, because this should be our norm. You know, what's wrong with us? We walked into the NHS to do the right thing. We want to do the right thing, and we need the tools. We want the tools. But by comparison, if you did the opposite, it all just went pear-shaped. Everybody did their own little thing in their silos, and I won't say any more. To address this implicit and explicit biases and racism, we've talked about that all the time, but we've got to do this in a safe place. Today is a safe place. I know it's been on YouTube, but it's a safe place, okay? And when we teach and we have our bias and unconscious biasness, we all have it, including myself. I'm going to share 30 seconds of my own life. So I was really sad. I was a first year medical student, and I wanted to save the world. So when I was doing medicine, I went to go and try and be a childline counsellor. So I did the whole year. My dad was dying of cancer that year, so it wasn't a good year. So I was trying to do medicine, thinking about my dad, and maybe I'm using my excuse. And I did the whole year of childline. And then it came to simulation and modelling. And at the end of it, I was told, after they tested me, you can't be a childline counsellor. And it's not because your dad is dying, it's because when you listened to a brown girl on the phone who wanted to leave the house, you turned around and said, go and talk to your mum and dad. All parents talk to you. I was giving my way of looking at things, okay, in my little world, and not telling her the right thing. And rightly so, I did not become a child. Okay, so I'm sharing that with you because I'm trying to help you understand we've got our conscious and unconscious bias, and I've spent the past 25 years learning to improve that, and tell me if I've got it wrong. So our mission of what we want to do is really understand how we can understand ethnicity and recognise it. And I'm now talking about, without the biasness, about us as educators and what we want to do, okay? The alter the assessment, and I know Karen's gone into this, I'm not going to discuss it again, that preparation and recognising people. And when we talk later on, these are some of the things we're going to discuss. I've stolen this from Natasha. Thank you, Natasha. Stand up, Natasha, for those who don't know you. She's the co-chair of ASPI. She won't stand up, but she will. ASPI special interest group that was delivered and developed in this past year because of the work that we've been doing. But really, we want to use this because it's not just about maternity. We've got to get it right in the other settings about how we record skin colour, role play, family. It's come up today so much, okay? Families, different families, people that don't look like us, and ask the right question and gather that information that I told you about a little bit earlier. And then looking at people's BMI, looking at their size or their weight. So if you've got the 4'2" woman who's lost a litre of blood, she's actually quite sick. You might have written in your statistics that she's lost a litre of blood, but hasn't come out of her bed at postnatal. This is our responsibility. I'm talking to us as health professionals. So what we're saying is that the toolkit that we're developing for education and simulation, with factors, the institutional, the culturalness, and the awareness, what Michelle was talking about early on today, we've got to bring this all together. So, upcoming things, I'd like Tuesday the 16th of September, we're going to talk about incivility in the obstetric unit and how simulation can help in that. And then we've got maternity and mental health webinar, which we are, actually it's not October, it's December, forgive me. It's definitely not October, too soon. But Monday the 8th of December. But if you look at the ASPI Society conference stuff, you'll see it there. So what I want to say is that we've got to mind the gap, but we've got to build the gap and bridge it. And that's what this work is all about, and remain patient-centred.
Thank you. Thanks, Nita. That's great. So we're just going to swap the order around. Ed hasn't given the talk on translation services, so he's going to come and do that. On to Simon to discuss anaesthesia. So let me just take that off. Great.
So another part of the work I've been doing is both with and their maternity reducing inequalities care bundle teams, and we've been working on interpretation and translation. So I'm just going to show you a little bit of this. Obstetricians think about using interpreters in our unit in order to contextualise it. That's knowing what your sort of local situation is. This is a really short presentation. So a survey of obstetricians and midwives across London showed about 40% of people use an interpreter daily, 44% weekly. So that's nearly all of us using an interpreter as part of our everyday job. In my GDM clinic, 1 in 8 patients needs an interpreter. So as you can imagine, that takes quite a bit of time. In terms of what we're using, telephone's the most common, and about use the telephone the most to provide interpretation. A lot of trouble finding face-to-face interpreters. And quite inconsistent with how we book them, to be honest with you. Video interpreting, this is held out as the and the interpreter on wheels and the screen, and I never know where it is. It's always out of batteries, So, and we now have central telephones bought for us for information governance, but that's locked in the drug cupboard. So we all use our interpreting. That's what we all do because that's what's accessible. Biggest challenges: delays getting an interpreter. We all sat on hold for a long time. That should be prefaced by perceived and actual. And I think it's a big problem, quality control. We had a really enlightening session with the GSTT in-house employed interpreter, who I think was a Spanish and Portuguese interpreter. She said, I get paid a reasonable wage to come and do this, but the agencies that trust him, by the time that the contract bid goes out, working for public service institutions are not necessarily going to be those who can attract the best salary. And I thought, wow, because that's a huge other issue as well. What do you do if there's no interpreter? Google Translate, family and friends, multilingual staff, rescheduling appointment, huge issues with all of these. So all of us have come across this every day. What do we think is needed? More interpreters are wonderful. And when anybody breathes a sigh of relief, because I know that actually they're going to get the nuance of the communication in the room, they're going to be able to pick up on the vibes, they might get as opposed to doing the ironing. More access to resources that allow for video interpreting. I'm not sure about this. I'm not sure if I want a video interpreter in the room. I don't know if anybody else does. More time and 24-hour access to interpretation services, absolutely. Better resources such as phones. Well, we've all got them. We just need to find a way to use them that's sort of safe for people's information. So this brings us to one of the bits of work which my colleague James Harris, who's a fabulous midwife who works with NHS England and London, is doing. And essentially it shows that not many of the good training in how to use it in our work, especially if you work anywhere, mixed, diverse, I'd imagine London, Birmingham, Bradford, it's all the same. So very little training on how to do it. Is anybody aware of the guidance that NHS London has produced? No. Huge amount of stuff that's done centrally that never gets out into clinical practice. And I learned a lot about what NHS London did when I went and worked with them. I hadn't heard of most of it. So these are the themes they're going to use. Training for staff. So it might be an e-learning package, probably will be an e-learning package, on impacts of communication, best practice, roles and standards, legal and ethical issues, cultural competence, and managing emergencies. So I went back to our unit and I worked with Marissa Taylor-Clark, who's one of our consultants here, and 2 fabulous BSc students who are working with us on our reproductive sciences courses. And instead of giving them a lab-based project, we said, come into the labour ward with us, what you think about using interpreters. And I'm just going to give you the headlines. First for the midwives, because they always come first. Most important takeaways. In our recommendations in maternity for translation and interpreting, we have largely ignored the practicalities of needing an interpreter throughout labour and birth. Haven't we? They're in labour, women are in labour for hours, sometimes days, long periods of times, waiting for surgery, during surgery and afterwards. You must use an interpreter for every clinical interaction. What do you do with that? So you do see some areas of good practice where you have, as you say, bilingual do every woman all the way through. So I think we've largely ignored labour periods. We found, talking to midwives, that they didn't rate their interactions as clinically crucial as those that they saw the doctors having. So they said, okay, we don't need the interpreter. The interpreter is a scarce resource. we'll just keep it for the doctor and we won't call up. This is what they told us. They also talked about the value of non-verbal communication when looking after women in labour, creating and building a relationship, and how important that was, and how actually you could do an awful lot of that. You could create a sort of nice environment. So that was really quite revealing as well. But I think largely we've ignored labour in our interpreting. So I'm not going to go through all of this. The slides will be shared, and this is all the students did, which was fantastic. Obstetricians, this is actually a shot of the first uterine transplant baby born in the UK by our obstetric midwifery and obstetric physician team, correct? And anaesthetics. Time, cultural barriers, and unreliability of interpreters just keeps coming back. Most important takeaways: the more senior the obstetrician, the more likely they are to use an interpreter. So the busier, far more likely to use an ad hoc tool like Google Translate rather than getting a translator on the phone. And then the time taken and the perceived reliability of the interpreters affects how care is delivered. And I think this isn't as much detail if you're going via an interpreter. And generally, obstetricians told us they practiced in a more cautious and defensive manner when looking after women who they were speaking to through interpreter, likely to offer an intervention than to let things run. So having this barrier in communication led to perhaps, you could say, more intervention in labour. Future work, we're doing the same sort of thing with patients at the moment, and as you can imagine, that takes a lot more resource because you need translators to assess the translators. And I think the sort of things we're going to come up with, a test card. So, you know, you give somebody a caesarean section consent form to translate, and then you see what they translate, see what comes out the other end, and see how much it resembles the first part. And you can have a series of test cards for interpreters to quality assure them. Anyway, that's just an account of what we're up to here, what we found, and we're looking forward to the work from NHS England that we can actually use it in our use.
Thank you so much, Ed. That's amazing. I think you're going off now, Ed, are you? Yeah, okay. Okay, we'll get a chance to clap you when you leave then. Waiting for Samia to come and speak. So she, as I said, I love anaesthetists. She's an anaesthetist, actually, she's been there from the very start when we had the first co-production workshop, which is that UCL Partner Simulation Network, and kind of managed to bump into her again more recently. She's like, what have you done with that work? And in terms of how the anaesthetist delivers their care. And she's got some really fantastic insights she's going to give us about, you know, uptake of epidurals and how it affects.
And thanks for inviting me. I'm Shiva. I'm one of the anaesthetists knocking about North Central London. Now, I actually took a picture of this statement. It is in the hand of healthcare professionals I meet on my journey. And I think that's really important because the journey of a woman, preconception all the way to postpartum and as a mother, is highlighted and signed by different interactions with different people. And I think one thing we do, what impact we have on the woman, not just from a clinical point of view, but how that then carries on to how that woman goes on and experiences her relationship with her children and with others and with healthcare forever. Anyhow, I have no declaration of interests. I have any conflicts of interest apart from the fact that I'm a jobbing clinical obstetric anaesthetist. Now, not everyone actually knows what anaesthesia involves, and as a matter of fact, most people anesthesia, including myself sometimes. So we are doctors, and interestingly, we go through 9 years worth of school. None of that training has much at all about as a population and how our differences result in differences in outcome, how we perceive our patients. And I'm sorry to say patients, because actually when we're interacting in the clinical setting, and certainly definitely as anaesthetists, it is a patient setting, sadly. We're governed by the Royal College of Physicians. I'm sure lots of people are also surprised, the largest specialty in hospital in the NHS. Lots of 3 groups of services. Pain relief, so anyone who has short-term pain or long-term pain, so acute or chronic pain, is seen by an anaesthetist in hospital. We knock people out for their operations. So anyone who has an operation gets bored to death or knocked out by an anaesthetist. And we provide resuscitation. So anyone who comes in critically unwell in hospital, as soon as they get into A&E, in order to help stabilise and keep the patient alive. And so it comes as no surprise that in obstetrics and in maternity, we're there probably before birth, definitely around on the labour or during the birth, and sometimes seeing women after their delivery. And actually the whole of medicine, as was highlighted early on in the day, there are disparities in medicine, and obstetric anaesthesia is no different. I'm not an academic, I never have been, and I don't think I ever really will be, but I'm particularly interested in why day to day. And so I approached one of my colleagues who's much cleverer and is a bit of a nerd to say, right, we need to kind of ask some questions, because actually we need to come up with better answers and with some solutions as to how we can address some of the disparities. So he said, let's have a look at what the differences are. And so we had a look at the literature, and we pulled some data how often women have pain relief during labour. And so in 25 articles that we pulled together, they had data for 13 million births in both the UK and the US. And what was the most difference was how Asian and Black women are much less likely to receive epidural pain relief. Now, that in and of itself is an interesting point. Now, whether that is lack of access, lack of uptake, this is really an important question that we need to address. And hopefully part of this talk is also about sort of some of the questions that should be appearing in our head, and it's a shame that Agnes is gone, but I would like her to because I think we're really trailing behind from an anaesthesia point of view. And likewise, when you look at anaesthesia for caesarean, anaesthetics are less safe than other forms of anaesthetics that you can have for having babies. So why? Question to be asked for everyone. And for the sort of the last bit of what we do for a living, we resuscitate people. And last year we looked at all arrests during operations in the UK, and that was run by the Royal College of Anaesthetists. And really interesting data came up, which showed the demographic of the study population throughout that whole period in the UK was similar to the general population. And somehow, in obstetrics, more than any other, and that Black mothers who accounted only for 6% of the pregnant women having an anaesthetic ended up with 21% of the cardiac arrests. So that in itself is quite similar, I suppose, to what we see in Embrace and in Embrace reports. How can we change this, and how can we change this from a training point of view for clinicians? And when Karen told me we're going to be talking about education and training for an equitable maternity system, I thought, right, it's definitely got to be multidisciplinary in every way. In that if we identify our own challenges, there may be a very weird picture of quite morphed for you. So when I thought back to medical school 20 years ago, I thought that medicine is, or should be, all about, well, health promotion. We should be good at diagnosing when things go wrong. So when things should offer management that is evidence-based and that will help the population that we are seeking to treat. Medical education in terms of academia, in terms of NHS training trusts, because most doctors train actually on the job after medical school. You do your specialist training as a paid doctor, and you pass some exams, and then you become a consultant. Sadly, there seems to be a gap in what and how we are trained in order to provide equitable care. So from a health promotion point of view, I think a lot more people have articulated that lead to inequity and how we should get equity earlier on in the day. But I think it is important as physicians to acknowledge that there are biological and increased susceptibility in certain conditions, but without pathologizing people in front of us, without scaremongering people in front of us and treating it as a person who has different aspects of their lives and their susceptibilities, but be able to be culturally humble enough to, and actually aware enough to understand what can affect the person in front of us. And there definitely is insufficient attention to community, as beautifully outlined earlier in the day. But from an anaesthetic point of view, I think one of the things we don't do particularly well as a group, and partly because of a lack of interest in the subject, partly because there is not much representation of black women in anaesthesia, but to see pain relief as a right for everyone in whatever form. It doesn't have to be through an epidural, it can be gas and air, with the sort of increasing environmental sort of reducing gas and air use in certain parts of the hospital, and whether that in itself would disadvantage certain groups who don't want to go for an epidural. That needs to be anyhow. From an anaesthetic health promotion point of view, I'd like women to explore pain relief options before labour, and I think that was the fifth bit of, and I would like anaesthetists to be a part of it, because actually this is what we do, this is our bread, and this is what we're kind of experts from a clinical point of view, sort of our expertise lie. But this is where it's important to start to collaborate, compile and deliver information and that's accessible. And I think one of the sort of three things that I think are really quite key is language. So it's not just Leti or Swahili, but also how language is used, to make sure that it's understandable to someone who has only had third year primary school education, to someone who's post PhD, etc. But also where, and that's where you will never find in the community, and I think that should change. Online, our presence is pretty dire online, but maybe that's just a function of my age, and actually most importantly price. But I think to have to sell, a toe or a kidney in order to attend an NCT class is not really acceptable. And access to maternity pain relief. From a diagnosis point of view, it comes as no surprise that that women from ethnic minorities, and actually women, are not particularly represented in medical textbooks and not in clinical case scenarios. And as someone who's examined medical students, lack of representation of women from different ethnic minorities in our clinical examination, and actually that awareness as an examiner that there are subtle differences that we need to, as physicians, acknowledge and pick up on. The bias in medical technologies is particularly important in this context of anaesthesia, and obviously our own clinical biases. From an anaesthetic point of view, whenever we assess anyone, we go through the ABC, airway, breathing, circulation. When we're taught as anaesthetists to assess airway, we're taught to check teeth, open people's mouth, etc. And actually some hairstyles, so if you've got braids or dreadlocks, and when you're sent to sleep, that can make it difficult for us to achieve intubation. That's putting a breathing tube down. And that kind of leads to a whole kind of snowballing scenario in a stressful maternity situation where in a section, a woman's being sent to sleep, inadequate, because of lack of awareness plus time, assessment of the woman's airway leads to complications. And this is, you see that sort of lack of awareness of the women in front of us and how certain, maybe cultural, maybe physical, characteristics can have implications. From a management point of view, I think it's not a surprise to anyone that the bias that we see in our research in terms of clinical ignore women largely, plus ethnic minorities are the uptake within research, the recruitment actually within research studies is particularly poor in diverse groups. And lack within anaesthesia, where I cannot honestly to me that having an epidural will prevent severe illness if she comes from any particular ethnic minority background. There's more evidence that's coming out that suggests having an epidural during your labour is likely to reduce severe maternal morbidity, especially when you're having a baby prematurely. But sadly, that data comes from Scotland and teased out the nuances and definitely not teased out the ethnicities of the population that has has reaped the results of research on why epidural uptake rates are so low in certain ethnic groups, especially when we know that South Asian women are more likely to suffer from 3rd and 4th degree tears, especially when we know that black women are more likely to have emergency cesarean sections. And from a holistic management point of view, it's been shown earlier in this session that black women are more likely to end up bleeding. The cause of this, don't know, but from an anaesthetic, from a clinical point of view, more women are likely to need more cannulae. Putting a drip in, especially in maternity where it's big, it's painful. Actions that don't involve just medication in order to, and if we're saying that bleeding happens more often in a certain group of women, and this is exactly the same group of women who are not going to have adequate pain relief, what are we creating? We're probably creating a lot of birth trauma. And that's where I think calling an anaesthetist early might be of use, because if there's one thing we're in quickly and reasonably painlessly, and actually the use of technology like ultrasound can be really quite useful. And of course, we need to start in anaesthesia in our practice. A recent study published by one of my colleagues at UCL looked at recovery from cesarean section. And is it because we're not doing the right follow-up? Are we starting a population of women with chronic pain? And that's where we need to start to standardize our pain assessments. And there's sadly more data emerging, certainly from the US, that shows that if you're non-white, you're less likely to have pain assessments and you're less likely to have pain relief given despite reporting higher rates of pain. So we'd hope that education and training for equity would, one, include everyone in the team. Point of view, it needs to be quite well designed, multimodal type of training. So the simulation training, the practical sort of training on mannequins is so much more powerful if it's based on real life scenarios. But the interventions that we want to be using and implementing really need to be evidence-based, and that's where it'd be really good to talk to quite a few of you in the room, because I think anaesthesia is really and it's in putting in its insights within different groups. And so it's important to involve the multidisciplinary team and service users, whilst acknowledging all of our biases and hopefully advance equity in maternal outcomes. Thank you.
Thank you, Shona. That was fantastic. Guys, it's 3:30. What I'd like to do is get the panel who were in the last session to come up, please. Which is in, you've got to go in a minute. Okay, guys, shout out. Anything for team? Oh, come on. Come on, Sha. Questions? Yep, you go.
I can't get over that slide when you said it's working.
It's not working. Is it working? Is this? Oh, the mic's working. All right, here we go.
Hello, can you hear me now? Yes. Okay, I just want to ask another question. I can't go to the slide that you said where it mentioned you mentioned that they're less likely to have an epidural. Does that mean when they have an emergency, they're more likely to have a general anaesthetic, and so it's like a rolling
Absolutely.
thing? Okay, thank you. I was wondering if I was interpreting.
So absolutely. And this is really where it's really important to get some evidence as to why this is happening. Is it because I've yet to see a 10-page birth plan coming from someone who is not a certain demographic. I would love for more women to come with, to have the right information to give women and to say, listen, if you have an epidural, you're statistically less likely to end up with a general anaesthetic. That would be actually really quite powerful data to give. So that, you know, when you opt for an epidural or not, you know what the immediate pain relief.
Brilliant, thank you. Okay, there's a question here and then a question at the back.
I just, I think it's sort of more of a comment almost, or suggestion, advice. I run a clinic for women with female genital mutilation, and we do,
I run a clinic for women with female genital mutilation, and we do defibrillation under local anaesthetic in gynae outpatients. And we use xylocaine, so lidocaine with adrenaline, and usually. And we had we were told a few weeks ago that we can't use the Entonox anymore because of ventilation. I was just thinking about the structural inequality, and therefore the thing is now we've also found that xylocaine doesn't seem to be available anymore, so we're having to make it up the lidocaine and add the adrenaline as well. So it's just, just I don't know, as a comment, also system problems.
I don't know. It's the genuine honest answer. But I think to highlight this as will affect a particular group of women who actually have already suffered a trauma in the first place when they had the FGM, to then add when actually there are ways of making it more comfortable, so at least unfair, or discriminatory, actually, when you call it.
Okay, fantastic. One more question, then I'm going to wrap this up. Yep.
Yeah, this is a question, but it's in slight comment really. It's a follow-up from previous question about GA. It just made me wondering, I don't know whether you did say in a slide that GA is associated with more, and then this is what we're offering to women who are from
It's not that that's being offered, it ends up being more common. So, and I think this is start to disaggregate the data and get better quality data. I know it keeps sort of banging on about data, but if in an emergency situation when there's no time, general facilities are back up. So something about the whole journey that gets the woman to a point of we need to get your baby out now needs to be looked at. From an anaesthetic point of view, who end up with a general anaesthetic. Next time, demand some questions, make more of a fuss. And I don't want to push an epidural on anyone, but if there's one thing I know will prevent you ending up with a general anaesthetic, is having an epidural on board. And so ask for it and ask for it early.
Yeah, no, thanks for that, Shem. I think it's really important. I'll get you to sit down, and I think your work fits Sisha's and Cherie's work about actually upskilling and changing the guidelines, because maybe there's new work to be done. So lots of ideas and thoughts. I want to thank the speakers for the last session. We're going to, look, guys, I know it's a long day, but we're going to keep your energy. What we're going to do is go out for 10 minutes, come back with your coffee and sit here. Then we're going to get Anita from Irvine Mitchell and Manara to talk for about 15 minutes. And then we're going to divide into 3 workshops. And then we're going to finish with two workshops. Have a loo break and come back in 10 minutes, okay? See you soon.
And we'll finish before 5.
Yeah.
Also on the screen is a WhatsApp group to join. So it's just really, if you're interested in health equities, to bring us all together. The Slido also has a poll on it, if you can. So it's just saying, what one thing would you do to change health equity? So please just check on the link. It's next to the Q&A link at the top of your... Thank you. Sorry.
damage because of delay in expedited delivery labour. The claimant was successful, the reason why they were successful, but the judge had some choice words about the record keeping, described it as shambolic and appalling. There were various issues with the records in this case, but the key sort of takeaway points here, at the very least, notes have to be acknowledged by signature or initial. Records should not ever be altered without acknowledgement or explanation as to why they're being altered. And as medical lawyers, we do see instances where medical records are altered after the event with the benefit of hindsight, which is a big no-no. It's directed to see original records, to see records being overwritten, timescales being changed, etc. It's unacceptable that administration of medication is not recorded in this case. Was the case in Labour. Second case study, a bit more recent, concerned again a birth injury where a child was eventually born by emergency cesarean section, brain damage through chronic partial hypoxia. The case concerned mum reporting to the doctors that she had reduced fetal movements in the last day or so. However, the SHO notes, largely legible, but they recorded active fetal movements. They didn't say whether they were seen on the ultrasound scan, whether they were reported by the patient, any detail as to any reporting, any observation, any history taking. And so the judge again found that the medical records were substandard, and because they were able to discredit the medical records, then the reliance was placed on the witness evidence. Obviously, you're all busy practitioners, you won't remember every single patient. When it comes to 2, 3, 4, 5, however many years after the event, to give witness statements and rely on it. If they are not up to scrutiny, then the patient will give their version of events, and in this case, the patient was found to be a credible witness who remembered very clearly reporting the reduced fetal movements, and the judge found that she was correct and the SHO was not. So the bottom line of the case studies is that if your version of events is open to challenge, and however well you've delivered the care, there is a question mark there if it's not appropriately noted down. Read them all out to you, you can have a look at them later on in the slides. And the conclusions, and again, you probably already know all of this, but it's, and I know Karen was talking about midwives, superheroes, writing everything down every 15 minutes, and from our perspective, that's what the expectation of the court is. I know it's extremely difficult, and the judges acknowledge that, but they expect to see the observations written down, and if it's not recorded, do it. Moving on to consent, as I say, whistle-stop tour. I won't go into the history of consent, but you can see there a 1957 case which sets out medical negligence, and a case that defined it, refined it, which I hope that most of you will be familiar with, the case of Montgomery. Apologies for the title there, Lancashire Health Board. Another birth injury case where Mum Nadine was very worried about having a big baby, and throughout her pregnancy she kept asking whether the baby vaginally. She was concerned about it, the doctors dismissed her concerns, and then she went on to have a vaginal delivery, and her son suffered a brachial plexus injury in court, because Mum said that had she been appropriately advised of the risks of having a big baby vaginally, she would have opted for a caesarean section. She was never given an opportunity to have. So Montgomery judgment found in favour of Nadine Mum and introduced the concept of material risk. So up until that point, the medical professional was the gatekeeper of the information. They would decide what was relevant, and that was it. Whereas now, the clinician has to recognise that each patient is different, each patient has their own circumstances, they will all have their own, not only their medical history needs to be considered, but everything about them, so are they a carer, their lifestyle, etc. And then the clinician has to think of what risks are reasonable for them, and then what risks attached to them. They need to then present those risks to the patient, and then the choice is made by informed consent by the patient, knowing their risks. Of informed consent, just to show you that it's not all on the clinician. In this case, Mr. McCulloch sadly died from cardiac arrest, having previously attended. The question was whether the offer of those drugs
was one of those reasonable options that should have been put to him, and the court found that the cardiologist, who was an experienced cardiologist, felt that there was no need for AIDs because there was no pain reported, and so the court agreed with that and found that the professional has to think of all options available in their own judgment. So it is for you to decide what the reasonable options are and then present those to the patient. They don't have to be options. Everyone recognises that you don't have the time to be going through them, but you make a professional judgment. You present it to the patient. You advise them of the risks of and benefits of that treatment option or with the patient. So there's just a few things about informed consent. What does that mean? Discuss the nature of the treatment you're proposing. Consider if there are any alternative treatment options. Are they reasonable? What material risks are attached to them? And then answer any questions. Very brief case study about how not to take informed consent. Mrs. A was pregnant, again another birth injury, but Mrs. A was pregnant with her first child. Although she had pre-existing conditions, it was an uneventful pregnancy, so the plan was to deliver vaginally. Her waters broke, everything was okay up until 6 centimetres dilation. Progress stopped. The obstetrician wanted to deliver instrumentally, Mrs. A declined. And the common theme throughout here is that at every request to deliver vaginally, the obstetrician didn't give any explanation. So the offer was declined a number of times. The obstetrician then spoke over the patient and tried to obtain consent from her mother, her birth partner, who also declined to provide consent, but eventually the patient felt so pressured that she agreed to the instrumental delivery. Excessive pulls with kiwi did not result in delivery, and so forceps had to be used, and this resulted in an injury to the baby and to the mother, and as you can imagine, a traumatic birth experience for the mother. A GMC investigation was conducted, internal investigation. The communication was found severely lacking, and actually a GMC investigation revealed there were other patients that had been affected. But what's clear from this case study is it may well be that instrumental delivery for this patient in terms of risks, but because she was not advised of why it was needed, why it was better than other options, she actually asked for a caesarean section if intervention was needed. That here, involving the patient in making the decisions, explaining the risks and benefits to them is the key takeaway point. And that brings me neatly on to, I feel like I'm racing through this. Case study, this is from an actual case Owen Mitchell has dealt with, and sadly we see these cases, a lot of these cases having very similar themes. So a South Asian first-time mum in her 20s was going to have a very big baby. The baby was growing along the 97th centile. That the growth of the baby was discussed with her at any point regarding mode of delivery. Not only that, but on 3 separate occasions recorded in the notes that she requested specifically a caesarean section because she was concerned about delivering the baby vaginally. That was 3 times with an obstetrician, 1 time with a midwife, and at each point she was told that she was young, it was her first baby, and she had no underlying health conditions, therefore vaginal delivery should be absolutely fine. Ended up having a forceps delivery and an episiotomy at 38+1, and she suffered a second-degree tear, which was identified and repaired. Specifically in the notes, there was a note of repair. However, after birth, for a period of about 2.5 years, her fecal incontinence symptoms got progressively worse, and so 2.5 years, and they diagnosed a large rectovaginal fistula and a 4th-degree tear, which was missed at delivery. And so this case shows what we see in our practice, the key themes. So South Asian women, the risk is 6 times greater for South Asian women to suffer 3rd or 4th-degree tears. There is a failure to advise of personalised risk and take informed consent, so that refers to ethnicity, but also big babies, and that's what we keep seeing. She was told she didn't need a caesarean section and she could proceed with vaginal delivery, and the options available were not explained to her. And this takes me back to when I was pregnant with my first baby, 2020. I got a leaflet from my local that said that although they're aware of Montgomery, They don't offer caesarean sections for maternal wishes. Luckily, since then, I've had 2 more booking appointments and they've removed that leaflet, but that's concerning. Advocate for themselves, don't know their options, simply go along with that. They think that that's the only option available to them. Don't question the medical professionals. Incorrect grading of tears, and strikingly, I thought it was normal. That's what the clients tell us when they come to us with the injury. Culturally, they might feel that they can't talk about it to their family, friends, might think that they're expected to enjoy motherhood, not complain. And so it takes quite a long time, the case I've just talked about, 2.5 years before the client saw the colorectal team, symptoms. And then invariably, these injuries have an extremely huge emotional, physical and financial toll on the patient, the health system, and the government, who ends up having to pay the compensation payments. And so here, and I won't go through it in a large amount of detail, but this is just for your own interest, how we as lawyers value pain. And so there is, the law needs to put the patient in a position where they would have been but for the injury. In these cases, obviously, that's impossible, but monetary-wise, the court tries to compensate the patient for what they've lost. So there's an award for pain and suffering, loss of amenity, the embarrassment they feel, emotional distress. That is set by judges, £1,000 for the injury itself, depending on severity of symptoms. And then the impact of incontinence, that can be an impact on employment. Women come back to work, how long it takes them in the morning routine. Childcare, they might not be able to cope with that, with household chores. All of that needs to be replaced on a private paying basis. Physical treatment, again, we claim for that on a private basis. That can be SNS, irrigation, therapy. Psychological treatment, often EMDR for the trauma that they've suffered, again on a private basis. The NHS waiting lists are very long. Aids required for the rest of their lives, additional things, it all adds up. We're looking at absorbent garments, we look at it in extreme amount of detail, add it all up. But these cases can easily result in 6 or 7-figure settlements for these treatment costs. The cost to the sort of tax system of the women not being able to return to work in their full capacity. We can see from that just how expensive those injuries can be, not to mention the extreme toll on the woman. And so at Elwyn Mitchell, we're really passionate about raising patient awareness and the theme of today, trying to educate to make sure that we see less and less of these claims coming through our doors. Thank you.
Just quick couple of questions. Does anyone have any burning questions?
Thank you so much. Can I just ask you a question about 15-minute recording? So, for example, in second stage of labour, you have transcribing into the records. If that's okay? Because we do that.
There is a recognition that some records will be written in hindsight after the event as well. It's the contemporaneous record keeping needs to be however you can do it in the very extreme circumstances of labour.
And another question, well, I used to work in a birth centre many years ago, but when you're facilitating a water birth, it's really difficult when you're listening into the FH in second stage. So we would write it on paper, but in latter years, thank God, we would put that paper into the records as well as into the electronic records. I should say we put the paper into the handheld notes. It's difficult when is there any cases around providing care for water births in second stage?
I mean, there's a lot of water births,
yes.
But I think however you do the notes, it's important to keep those clearly not altered in any way that then form part of the electronic notes.
Okay, thank you very much.
Can I ask you quickly, if a trust doesn't train their staff in providing care to the high-risk women, is there a way you can sue on a corporate basis?
Under all these legal ones or against the trust anyway, isn't it?
The cases are, unless it's a private practitioner or a GP, we do pursue trusts and not in the patient, in which case, yes, we can pursue systemic failures as well.
Thank you. Any other questions? Sorry.
You're probably not required to do it, but I just wonder whether you gather the data. Do you produce reports? Do you ever produce guidance so that trusts can use the information? Because you obviously, from all of the cases that you see, there's a lot that can be learned to improve practice. I mean, that might not be helpful because you mean that you don't get as much business, but I just wondered.
Thank you. Anne Kavanagh. I'm also at Owen Mitchell. NHS Resolution, which is in England anyway, they keep data on themes, just as MNSI and HSIP keep their own reports from time to time on themes they see emerging in care. NHS Resolution produce reports on themes they see across claims, whether they've been successful or unsuccessful. At the moment, there's some doubt, there's a question mark over whether those themes are fed back to the individual trusts, and also the time lag, because our claims often take, 5, sometimes 6 years. Staff have moved on, systems could have changed, guidance and so on. I think that with the introduction of MNSI reports in particular, there is an opportunity there for a more agile response and a change to systems more quickly. It's not necessarily dependent on whether the claim is successful or not.
Very much. I think we've come to the end of that session. I just want to introduce Manara, who has been the secret superpower in the work meeting. She essentially, we saw the LAN work that Nandi put up at the beginning, which is the local implementation network. She's basically the sort of coach or quality improvement expert or guru that really coached us through that process. And so we're so privileged to have her talk about how you create a roadmap for equitable methods and start doing your own. She'll take us through it, so I'll hand over.
Thank you, thank you. Very, very conscious of time, and I'd love to, because you've been listening to a lot of presentations. So as we think about this work, one of the things that we've been doing through this Learning and Action Network is really thinking about what are the practical steps to take forward equity work. How do we actually do it? So we've been advocating a lot for integrating a improvement methodology with equity. Now, whether it's racial inequalities, and that's the work that we've been, or a broader framework like the Core 20+5 framework that you're no doubt aware of. So what I would want, what I wanted to do today is just, too far ahead. I'll share all of these slides anyway so that you've got them, but I really wanted to start to think with, how do you actually come up with your charter? And this is what we've learned from the work of the Learning and Action Network, but more generally, so some of it may actually be quite basic. So thinking about the found steps that you look at, the first thing, and you would have heard Nandi say in her keynote this morning, is acknowledging that there's a problem. Naming racism is one of a particular team wanted to work with South Asian community. When they took it to their maternity group, they said, no, there's no problem there. Why do you want to do that? And they said, well, but our data says this. Maternal health referrals are lower for South Asian women than they are for black women or white women. So why not? No, there's no problem there. And it took them weeks and weeks of gently, and then in the end, the exec lead decided she'd do it. And there's a gap that needs to be resolved. Is one of the first things you have to do. And then looking at the root causes of that gap. Thinking about, why is that gap happening? Is it systemic racism? Is it a process issue? Is it an operational issue? Is it a policy issue? But understanding, really getting to the root cause of why that's happening. about the no-do gap. In some cases, we know there's a problem, yet we do something completely different because that works better, that feels right, that feels comfortable, and it's easier. We have to come out of that. We have to address the no-do gap. So we have to think about what are those actions that we need to take. So in terms of the first step of building that foundation, these, if at a very simplistic high level, I'd suggest these 3 things that you start to look at. You then need to think about methods and methodology you're going to use, and you continue to advocate for the work and build the case for change. The methodology is really important. So for the Learning and Action Network, we use the model for improvement. That worked really well. We were able to teach that approach. We even integrated the anti-racism principles into that model for improvement. So we mapped it so you could see at what point do you start to name racism, at what point, etc., etc. So step 2, methods and approaches. What methodology are you going to use and how are you going to make that happen? As you continue to build the case for change, you're going to build a aim statement, you're going to come up with all of those things, because that's what's going to help you to really get to and drill down and get to the bottom of what you're trying to achieve, why you're trying to achieve. And Karen will tell you, as I talk to her about the LAN, I'd focus on what is your population of focus. Be hyper-specific. Don't go generic and then find it's too big, too large. And then step 3 is about learning. Think about all of the sources of information that you have in order to validate and confirm that your theory so far has been correct or you're aligned. Look at your data, and we heard Ed talk this afternoon, earlier this morning and this afternoon about data. So critical. Use your data, use routine data to build your case about your population of focus and your thematic area. But learn from staff. Staff usually have really good insights into what's on a system in a theatre at the antenatal care area, in the outpatient area. So they really have a really good idea. Hold focus groups, talk to the staff about that. In the work that we've been doing in the Learning and Action Network, we really ask people to do at least 10 to 15 service interviews to learn from mothers, learn from members of the community what was happening, and really, again, a good way to engage and really to build that learning. And then, as you take that forward, you agree on the area of focus, you define your population of focus. Are you going to look at postpartum hemorrhage? Are you going to look at gestational diabetes? You're again continuing to build that specificity of area. This is what I want to focus on. And then you're going to design your actual approach. So I have a whole set of slides that go beyond this, but I'm not going to go through all of those, but we'll share those out with you. What I'd love for people to do are flip charts. We could have another flip chart, just a sheet would be fine. And it would be great if you could just spend 5 minutes, 7 minutes. Can we take 7 minutes, Karen?
Yeah, definitely.
7 minutes to just brainstorm together. First of all, do you think that this framework would work? Just in this very high level, looking at learning about building the foundation, looking at methods, learning and developing the design. But really thinking about into a charter, if you were going to go away tomorrow, and not tomorrow, Saturday, Monday, and start working on an improvement aim.
If some of you can come sit here.
Brilliant, thank you.
Give us these again. So this is, you've done all the hard work with this bit. This is the easy bit now. Pen and paper. And did they have to check in there? So if you want to choose something to change, what would you think about changing? Some of you want to come and join us here?
Do you want to come down
Actually,
here?
On your Slido as well, there's some polls if you wouldn't mind it.
Yeah, try and find some more.
Okay, okay.
I have one on yours, I found one.
First of all, do people want to think about, is there a gap, would you say, where you work?
Some ideas.
Yeah? Do you feel that you work
try and build out charts
I love the way you start smiling. Does anybody care to share? That's very powerful. So then, so it's about other, because often actually we're the people here in the room, we're really kind of like believers. It's like giving ourselves the tools to go back and make a change in our own units. And you can see that when people talk to the board, a lot of it is about experience. And most people have the narrative that actually all women have that experience, regardless of colour. So what did you see that we did that made a difference in terms of actually getting people to acknowledge there's a gap? The next stage, the next phase. Yeah, using data. You have to use the data. So it can't, I don't think in this space it can just be qualitative data, unfortunately. I think that really helps to set the scene, but lots of people want to really think about how you can go back and get that data in your system. Has anybody got access to that sort of thing, or go and do that?
I really like that, so it's not just about it's actually their whole village, right?
And one of the barriers is no matter how much you say the data centers, particularly the end-based stuff, that is something that people hear all the time. It's almost uploaded to the bit.
Yeah.
I guess the challenge we're finding now when we're delivering to all bands, all people, especially like say, you're not necessarily that robot, other things to get it.
Yeah. Yeah.
It can still be a huge factor.
How do you think we then do antenatal care that well? How do you think that they access all their communities? Do they know the importance of that antenatal care, visits? What about what we give them during one of the
session, and mothers said to them, why do you keep on giving us leaflets? I don't understand why you give us leaflets. We take them home and we put them in the bin, or we use them to put our tea mug on it. Why do you give us a leaflet? Why don't you do something different?
It needs to be about inclusive and intersectional pathways. So you're adapting the service to meet the needs of those individual services.
Because I think in handing leaflets there's an assumption that that's how people choose to receive information. So, is that information better given over a cup of coffee and a conversation, rather than a leaflet?
Just, again, it goes back to that anesthesia presentation about what somebody wants. Sorry, you were going to say.
I was just going to say, sort of acknowledging diversity of knowledge base.
Not just looking at the people, but doing the staff as well, working out what they nurture in. So there are lots of great stuff like, the CQC now, have some of the anti-racist stuff in there, but there are some key frameworks that we can use to try and really drive change, which are the policies, structures, guidelines which already exist, and perhaps with units what we used to do.
Understanding also differences
The other
that
things
will
that
come
I'm really
under that as well.
fortunate that I went to all the different groups, so don't forget, your midwife would be good to very not supportive.
What about our policies? What do you think about those? Do you think the policy framework, do you think the policies are sufficiently de-biased to help?
Pathways, shouldn't it? So it should come from your strategy, your policy, and then all of the operational procedural elements that you have.
So incorporate that time, cost, staffing, levels of staffing, consistent and continuing.
It has to all be aligned, doesn't it?
That feels quite good about kind of the pre-delivery part.
Staff well-being, yeah.
Yeah, so it's brilliant. So that kind of summarises where we said continue to build the case for change. No, which is brilliant. So I'm hearing here talking about culture and you embed things. So I'll tell you a quick story about civility saves lives. You know, if you've got a bully and you go and you address them and you say to them that you've really hurt that person, you'll get different responses. You'll get a very minority of bullies that will just accept it. You'll get the middle part that will be okay, somebody let's sort it out. You'll get the really angry ones as well, who shout at you. You've got that 5% of the narcissistic, probably another 1% that's probably got a brain tumor. But anyway, but within that, the angry ones who you think hopefully are, and so they will invariably, the vast majority of those, maybe up to 8% or so, will come back and they will change their behaviour. So although you get people that are very resistant to this whole idea about being anti-racist and what it really see that as
policies that needed to be devised. It's not a small task, it's a huge task actually to devise those policies. There's a lot involved there. Devising policies, we're saying that there's a lot of policies that need devising.
Is that information available?
Yeah, we can put you in connection through the Race and Health Observatory. They've actually worked on that. There's a
Okay, this finding is, what do you think happens to that group?
Sorry? Funding gaps, yeah.
Don't think it's always something you need to do. And then we got any more
questions about that?
And then so methods and
What about during delivery?
If you are not
ever joined
what kind of things
places like Health Foundation Institute of Healthcare Improvement, I would really encourage you just to join and get a newsletter. Well, they've got such amazing resources on there that you can use to work out the methodology you can use. And ideally, I think anything that you do like this, as you can see for Black Mothers Matter, if you go on and register it as a quality improvement project within your trust, you get oversight of that project. And whether you do it, it's, well, actually, this is part of the quality improvement initiative.
Yeah. So there's something about access to bits of birth.
Competency training, it should be part of the quality improvement initiative because we can do see and act and change it again, the whole cycle. And essentially you adapt to each one as you go along, so you work out what's working and you move on in the next sort of cycle. You then learn from the data, you learn from your staff and you learn from your patients as well.
And then in terms of
where for those women the outcomes have been shown to be rates of OAC.
Ask you to call out one area that you're going to change and go back. And what you'll need to think is focus, what population you're going to address.
And I think you'll probably find that in total across the UK they are probably less likely to access those settings, and you have to think why that might be the case. When for a group of women that better space for them.
Okay.
It's also whether they even exist, those settings, not sure, but also whether they know about it and understand it.
Yeah, that's about.
And whether they're informed, yeah. What about
I don't
Pick
work in
a
a clinical
The women doesn't have to be
environment,
clinical. She can't get away with it now. So you're already doing stuff, aren't you? Do you want to tell us a little bit about your poster?
Yeah, but I'm an academic. So
It doesn't matter. We need academics. We need academics for the...
Right. So yes, what I'm interested in is trying to figure out where some of the factors that create the gaps, and specifically ethnic gaps in maternal morbidity. What part of them are related to any biological difference that could be genetic, etc., and how much is actually related to the care that is provided and preconceived idea about diversity that are applied, and therefore.
So I love looking at your poster, which was great, when she looked at basically the outcomes, birth outcomes, mode of delivery, essentially you were looking at between black, Asian and white women, and you showed that black women, they have a high emergency cesarean section rate, but actually also they have the highest spontaneous vaginal delivery, and they have the highest failed instrumental delivery rate as well, and lowest forceps delivery rate as well. So we were talking about different factors about how it might be that we've got these models that tell us to define how to examine, and they're all based on station. Look at how dilated they are. We're trying to assess the pelvis just with our hands as we examine. And it may be that that's actually wrong for some of our black and brown populations, because of differences in the work about the lordosis of the spine with anesthesia. Oh, that was
mostly come from Shima.
Okay, for Shima. But that was great. And that's something that, although you think it sits within academia, is something that you could twin. So that's your, So thank you for sharing. And then would you like to?
During a neonatal intensive care episode, we want to keep the mother and baby together, because in those settings that's most important. But actually globally that's where the movement's going now. So how do you think about different ethnic? We account for those in the NHS?
For sure not.
Don't. I learned in Ethiopia they have a coffee ceremony that they do immediately post birth, and it's actually very important for them to do that. And that's what they do. In the Middle East, they have big family gatherings immediately after birth. So I've learned so many, and I just wonder in the NHS, do we ever account for any of that?
I think that's one of the important things that we don't account for is because usually we have all this conversation of who's can you hear it, etc. But we never ask specifically, are there any specific cultural or religious ceremonies that you want to take risks straight after, or we need to account for? And sometimes when it does happen, if the shift changes, or the new team comes in, or the big one goes away and another one comes in, then it just
gets lost.
Yeah.
The bias leads.
And then on to you. Hi, just tell us where you're from as well.
I'm Yewande, clinical fellow at St. Thomas Institute, obviously my probably maybe I'll look at how fibroids affect like delivery outcomes, and then maybe look at the difference between white, Asian, and black women, and if we stick to all our protocols between those different races. What is it?
How fibroids affect delivery outcomes? Yeah.
And the differences between the races as well.
Okay.
And if we stick to all our protocols.
Yeah. Brilliant. Thank you. And then hi.
I'm Maria, I'm an obstetrical physician back in Canada. I'm doing an acceleration.
Oh yeah. So, how did you find it? Yeah, Canada's done a lot of work around sort of nurse. Is it the Indian population?
First Nation?
Yes, that's it. Yeah, I looked at some of their stuff.
More data on the First Nation, but are lacking our preconception care in immigrants. So we don't have easily access to GP in Quebec, where I'm a French Canadian, where I'm coming. So I think if we can improve preconception care, so the obstetrical outcome will be very better.
Okay. They can't ask for what they don't know they're not going to get.
When we present to the hospital when you're going in, do they not say, okay, you get a birth plan, this is what it looks like, this is what it entails?
There is a discussion that should happen around that. Sometimes, for some of these women, not all of them, there will be other priorities, whether their bloods are correct or they've got other comorbidities, the baby's small, whatever, that's going to reduce the chance of that. If you've got a small baby, you've got gestational diabetes, or self-aging woman, we're just going to plan for a section anyway, so what's the point in having it? Do you know what I mean? They're not thinking, they've already got a bias. I've been exposed to what you need for that person. Now, in the PPH circumstance, that's quite a positive thing, because actually if you're thinking, this woman, a chance of bleeding her high, let me consider having a discussion with her so that we can
just in case.
If this happens, this is what's going to happen. We're going to offer you this drug, this person's going to come in the room.
I want you to move to London afterwards.
because I think there's a load of work we could do, and we could collaborate with lots and lots of teams who are trying to do the same thing and amplify all the great stuff that's already happening.
So if anybody wants to collaborate with him,
come chat.
yeah, just come have a chat and really connect, right? Yeah, and make sure you join the WhatsApp group because we'll get obviously everybody connected on there as well. That's amazing. Well done.
Well, I've been tasked already. I've been tasked with looking at reducing our lead bookers.
Reducing what, sorry?
Lead bookings.
Oh.
So we initially just sort of went with the tagline, period lead book by lead, and then we've just put that out to communities. We've had suggestions of what tagline should be, what means what to who. Some women talk about leads rather than periods, so we're in the preliminary stages of looking at that. So we've got a live survey at the minute to see what communities we're going to suggest that there isn't a target group, but there has to be. There has to be, so
yeah.
haven't.
Okay, brilliant. Well, we look forward to that next year as well. And then over to the
summary.
yeah.
I missed the initial bit.
About reducing late bookings. Yeah. And then over to you. This is a very
most birth plans don't go in the direction that you think they're going to go, and you've got her in the delivery, so you've never met her before. You're trying to undo everything she's decided she wanted, but she's not. No one's counselled her on what ifs. And then it does look like it. Yes, she's got a live baby, she's well, there's no tears, but she's gone home, she's traumatised because she wanted water or she wanted an epidural or you know. So to a certain extent, a birth plan is an I'd like to be served within the process of labour and delivery, but it's not. There's nothing definite about it, and I think that the fact that midwives are now having to do more than writing, constantly reporting, constantly auditing. Some things get lost in translation, and that's one of those things. So the people that come with a birth plan that's set up generally are white British, educated women who can get what they want because they've
said it and they've planned for it beforehand.
But then wouldn't the most meaningful part of a birth plan then be the conversation? Then what's important to you? Have you considered how you want it to happen?
Breastfeeding, all of those things.
Yeah.
Do you want it, if you want to touch the all of those things, but it's a 10-minute appointment. So
So maybe we should be calling it a holistic
Yeah.
because we're restricted.
there's a lot more to
Or is this something incorporated something as part of pregnancy?
That could be a whole project, right? In and of itself.
I was just thinking that's really interesting, just a project, and it's probably going to be fairly easy to pilot. Huge project. I think it's quite a nice it has a nice kind of framing around it to think about the birth planning process and a bit between kind of the process. I think that'd be a very nice project. Yeah.
It's very individual based. It's better than nothing.
Yeah.
That's what put me in my place.
Yeah.
I was like, it's not the best because I know it's not best practice. Yeah, it's not best practice. But actually, how do we, as a charity organisation, that we are using interpreters and actually should we then try to build those skills and really
Yeah. Thank you. No, good. Thank you so much, Tommy. Yeah. And then over to you and yours.
sorry, what was the question?
Just what you're going to change, take back and change in your unit, what project you're going to start, and what area you want to look at.
Alright, okay, so I'm Sandy from the BCSC sector, so we are running how Black and migrant housing is affected by those inequalities. I think what we're doing and what we've done is to collaborate.
Verifying the birth plan, because the birth plan has emerged because there's something within the system that is not what it should do.
Maybe we haven't got to the root cause of that yet.
I think so. I think that's
good provocation. Yeah.
I know I'm coming late. Coming back to Angela, I'm just thinking what the other team are saying. What are you going to take back?
Say that again, sorry.
What are we going to do different
About
to have that conversation?
To have the conversation about birth plans.
Yeah.
I think personally that it is one of the many issues that we have with childbirth, with maternity services, that have arisen because of the way that they have emerged, and it's not just health, because we tend to look at these problems as if they are just from health, but a lot of them are societal. Like, for example, the choices that we have. I know that women, you know, the way we've looked at birth now is that women should be given a choice, and that is very actually that's very kind of neoliberal, and it's like a marketplace, and you are able to choose what you want to have, and that goes really against the idea of what birth is. I mean, there is an idea that birth is a kind of it's a project that we have to do for it, you know, it's like the essential human project is to reproduce. So we come away from the idea of that into something entirely different. So I wouldn't be able to separate this from anything else. Sorry to kill that conversation.
No, I think what we need to do is think through, and each one of you, as you go back to your workplaces, and again, not knowing where your workplace is, of the things that we
situation that's currently in practice, and then we can use the toolkit which you, Dimitri, and everybody collaborated in creating, and we can implement that Imperial locally and see every policies, every local guidelines and policies that are made. Just goes through a simple checklist and just to incorporate that, and that will, even if 2 hospitals do it for their guidelines, have so many guidelines that will make so much difference, and we can present that to the college and we say that if the local guidelines are doing this, and we have already guidelines are having a bit of paucity, it will be so much beneficial to incorporate that. So we can show them the baseline data, show them the implementation data, and then propose them, and then we have a solid...
Really, really good. And we look forward to seeing the update next year. And over to you, Tash. Just looking at me.
2 things quickly sprung to mind when you said that. One is that we have another area where the referrals from different ethnicities is very vastly different, is out of birth guidance, and a lot of today has been about personalised care, and the placement we get for most personalised care is out of guidance birth, and they are very disproportionately white and of higher socioeconomic groups. Those are people who are getting that personalised care, and arguably they do least need around that. That's a very one of the things about postnatal contraception, all over the planned pregnancy, broadly speaking, has better outcomes than an unplanned pregnancy. Still, and the provision of the uptake of postnatal contraception, again, vastly differs by different ethnic groups, and how we can work with groups to work out how different cultural groups would want.
we wanted to learn about how we use an anti-racism approach to those clinical areas. Integrated, not clinical here, anti-racism here, but actually together. How do you address PPH? How do you think about referrals into a mental health clinic? So the integration part is what we've learned about. And it can be integrated, but it takes time. There's no quick win. There's no quick win.
As a baby, but always as long as you say, I think for anyone of the non-Caucasian, I'm going to say that let's get some information about your stuff, not just say, I'm just to get my colleagues to push it more, say, you know what, I need to go and talk to her about it. I don't want that, oh yes, I've done it, people, but what you don't have, and I will push them. Even if it's one woman next week, I will find that woman. That's what I did.
It's amazing. It's amazing. Thank you so much. I know that we are overrun. I'm so sorry, but I know that Karen will probably want to wrap up. But thank you so much.
Thank you very much. It would be great if you would share with you guys some policies.
I will do, and then I'm sure she'll be able to send
Thank
it.
you. We're online, I'll switch on.
Yes, how are you doing? Yes.
Pathways, but what is happening is the communication between the 2 teams, between one team and some of the staff thinking that because who they are, that's why they don't take their referral. So it's just look at that, whatever area to acknowledge that concern.
Maybe take that over there. Do you know what I love about what you said? You're probably one of the few, it's funny, we're always thinking about data and outcomes, you just said patient experience. And that's probably one of the big factors actually. And there are not many projects trying to improve the patient experience of a black woman. I don't think they exist. So that's a really good one. I'm really looking forward to seeing and hearing about that. Thank you very much everybody for contributing to that session. Did you want to give some final words about data, and then I will come and give some final bits and pieces.
So thank you so much for having those conversations. Hopefully someone will take a picture of the... Hi everyone, so sorry, just going to wrap up quickly. So thank you so much for having those conversations. I know in the little group that we were there on that side, so there's obviously a lot to do, and there's obviously things that we can do that are small incremental changes that will make a difference. The piece around using routine data to inform improvement, I think there's a real opportunity to do that. So do think about data. The advice I'll give you around data is don't fall into the data trap.
Sorry, I'm laughing because it's so true.
The data trap is you look at the data and you think, oh, that's not quite telling me the right answer. Then you go and find more data and think, oh, I'm not sure that tells me. Then you go and find more data and more data and more data. And in the meantime, you haven't actually done anything. So please don't fall into the data trap, is my advice. And I don't know how Ed would feel about me saying that, because he loves data. But from an improvement perspective, that it's not everything. So thank you so much. Thank you for having that conversation.
Thank you guys. So you are the last hardcore ones that are left, so you're going to be the most rewarded in terms of your learning and reflection. So please open up your Slido as the last thing that you do, if that's okay. So on the Slido, on the top tab, you will see there is, which is a Q&A, there's a poll on there. So you just need to click 1 or 2 on that poll. This is not the Slido, by the way. It's for to join the WhatsApp group up there. Go to slido.com and then just click on the polls rather than the QA at the top. So it's basically, what will you take back to embed in your organisation? Are you going to do something around simulation training? Are you going to do a guidelines assessment framework? Think about communication, darker skin recognition posters, ethnicity-based data evaluation, or PPH prevention protocol? Just one. So you can actually click more than one. So just a hand up when you've finished doing that poll.
I love the fact the sim stuff is coming. Can we share as a team that we will be sharing lots of stuff with you?
Yeah. Really look forward to changing for you. So we've got 16 votes, so just waiting for a few more. And then the next one is that I just want to know what you want us as a conference to focus on next year. We'll do this again next year. So the focus can either be around South Asian group and third degree term. I'm quite passionate about that. I also love really taking care of women in the postnatal perineal space and ensuring that they recover back to full strength. So I'm just waiting for that one. I'm going to finish that poll. It's 18 votes. Another couple of votes. We'll finish the 19 we've got to.
Great.
Yeah, who's voting? They're almost there. So I'm going to have to stop. I'm going to start the other one. Write it in. And then make sure you've screenshot the WhatsApp group. So please feel free to take one of the conference brochures. If you want to tweet or do any social media posts about the event and what you've learned, there's hashtag Maternal Equity 2025. Wow, equity made a delivery. That's a serious one. That's for next year. Somebody wants us to do that. And framework. Women as they age through the life course. That is interesting because there's a lot around the gender health gap.
Yeah, and linking into women reach into menopause.
Yeah,
Some of the issues
menopause.
phase of their life.
Yeah. Migrant mother, short case studies that were successful local equity projects for inspiration. Yeah, projects on health equity for inspiration is coming up. Posters from the amazing ideas in the last workshop, debiasing policy framework, bereavement care, fathers, women and staff to make a change, refugees and migrants. That's really good. Yeah, really, really good. And then when you get a chance at the back of the, on your way home, after you've had a section, you can fill in the Survey Monkey, and then we'll get your details from that, and those people who fill in the survey will get a certificate of attendance, and then also the resources either emailed to them. And those people on the WhatsApp, because we know you were here, so that's, we're almost done. So thank you so much. Give yourselves a clap, everybody. Time and have a lovely, lovely weekend, and thank you for supporting us. Wow.